I would like to welcome you to the second day of third annual Congress of Immuno-Oncology Society of India. With a great pleasure, uh, we are beginning our second day. For the opening remarks, I would like to invite Dr. Jyoti Bajpai ma'am, who is the organizing secretary of third IOSI. Over to you, ma'am.
So thank you very much, Rekha. And on behalf of my co-organizers, Dr. Sharma, Dr. Avasthi, I would like to extend this very, very warm welcome to open the second day of Immuno-Oncology Society third annual Congress. And let me tell you, this is such a pleasure moment for me that we have, after the conception of this society, we are conducting every year this annual Congress, and every year we are able to host world leaders in IO field. We have witnessed yesterday some brilliant talks by the world leaders in true sense, including the oration which is delivered by none other than Dr. Honzo, whose phenomenal discovery for PD-1, PD-L1 pathway actually revolutionized the cancer treatment today. Uh, Whole world is well aware about pembrolizumab, nivolumab, but the seeds of this great treatment has begun with Dr. Honzo's discovery. So with that, there were some more great talks, panel discussion yesterday, wherein we brainstormed with the world leaders. And thank you very much for your very active participation, your constant support. With this, we are beginning the day two. And now I'm handing over the mic to the master of ceremony, Ms. Rekha, who will take over the proceedings from here to start the first session, which is extremely important, especially much relevant in Indian context. So Rekha, over to you.
Thank you,
Thank you.
ma'am. So we are moving to our next session. I would like to invite our chairpersons, Dr. Pankaj Chaturvedi, sir. He is Deputy Director, Center for Cancer Epidemiology, Professor and Surgeon, Department of Head and Neck Surgery at Tata Memorial Center, Mumbai, and Dr. D.C. Doval, sir, who is Chair Medical Oncology and Chief of Breast Cancer and Thoracic Services at Rajiv Gandhi Cancer Institute, Delhi. Now I request Dr. Pankaj Chaturvedi, sir, to provide the session introduction. Over to you, sir.
Good evening. Good evening, everyone. The treatment of metastatic head and neck squamous cell carcinoma remains an area of improvement and hence research. The introduction of immune checkpoint inhibitors has significantly improved the outcome, but only a small proportion of patients are benefited. This has led to vigorous investigation of new biomarker and biomarker-based therapy. Novel therapeutic options such as adaptive cellular therapy and therapeutic vaccines are also on the horizon.
Sorry for the technical glitch. I again request Dr. Pankaj Chaturvedi, sir.
Good evening, everyone. The treatment of metastatic head and neck squamous cell carcinoma remains an area of improvement and hence research. The introduction of immune checkpoint inhibitors has significantly improved the outcome, but only a small proportion of patients are benefited. This has led to vigorous investigation of new biomarker and biomarker-based therapy. Novel therapeutic options such as adaptive cellular therapy and therapeutic vaccines are also on the horizon.
वीडियो है, वीडियो रिकॉर्ड करके दिया है, वो बार बार एक ही चीज रिपीट हो रहा है.
Rekha, I think you can invite the next chairperson for the further introduction of the
Yeah,
speaker?
I request Dr. DC Doval sir to invite Dr. Kumar Prabhash sir.
So sorry about the technical glitch. Actually, Dr. Pankaj Chaturvedi has to travel for some very important meeting. So this was the recording which he graciously shared. And we know we are living in virtual world, and there are certain technical hiccups which we only can apologize about it.
No problem, Jyoti. That happens in each and every meeting.
Right.
Good evening to all of you, and I think without wasting much of time, I would invite our speaker, Dr. Kumar Prabhash, who is well known to all of us. He is the head of Department of Medical Oncology at the Tata Memorial Hospital, Mumbai, and he'll be talking to us on advancement in the immunotherapy of head and neck cancers. So, Dr. Kumar Prabhash, it's about pleasure to listen to you, the work that you are doing, and welcome, Dr. Kumar.
Thanking the organizers for this opportunity to speak on immunotherapy in head and neck cancer. And what I'll try to cover is to find out the place and the kind of data is available for immunotherapy in head and neck cancer, and also try to see where it fits into our population. Starting with the recurrent and head and neck cancer, recurrence rate in early stage head and neck cancer is around 10 to 20%. But in the locally advanced stage, it is around 50% and more, suggesting that good number of patients, there is a recurrence of disease, and these patients, their survival is usually less than 1 year. The patients, majority of them, some of them, one can give some localized therapy with a curative intent, but majority of the patient, we end up giving systemic therapy with palliative intent. And the choice of treatment depends upon performance status, comorbidities, cisplatinum eligibility, finances, symptoms, and the tumor related factor, that is platinum sensitivity and PD-L1 status. We did a work that what patient wants. We know what we want, but we wanted to know what patient wants. This was our work which got published in Oral Oncology, and it appears majority of the patient, they want that there needs to be prolongation of life, but we do have a good number of patients who are happy with that if there is a symptomatic relief, and that should be borne in the mind when we plan treatment, that what patient wants in that particular situation. Till now, before immunotherapy, this was the best possible treatment option available for patient, which added life to the patient. That was when cetuximab plus chemotherapy was compared with chemotherapy, and it showed that cetuximab add life to the patient. That was around 3 months added, which is small number but significant. Subsequently, we had a development which was immunotherapy, and starting with pembrolizumab in first line setting, because we are talking about initially first line setting in recurrent and metastatic head and neck cancer. This was the study, pretty complicated one, called as Keynote 048. This is the design. You had a 3-arm, that is pembrolizumab alone, pembrolizumab plus chemotherapy, and then was compared with extreme regimen, that is cetuximab plus chemotherapy. The study endpoint, the primary endpoint was OS and PFS in CPS more than 20, CPS more than 1, and the total population. Remember, it was a hierarchical design. So if one of them would have been negative, they would not have taken the other endpoint to be analyzed. And then we have the routine secondary endpoint for PFS and OS, and the safety and tolerability profile for these patients. This was the baseline characteristics, and what we can see for age, gender, performance status, P16 status, current and former smoker, PD-L1 status, and disease status. By and large, all the arms were fairly well balanced. This is the data for overall survival, where pembrolizumab plus chemotherapy was compared with extreme regimen, that is that 5FU cisplatin plus cetuximab, and what we can see here, that it did add life to the patient, and from 5 to 6 months onward, by and large, every stage there was more patients surviving in patient receiving pembrolizumab plus chemotherapy as compared to patient receiving only extreme regimen. And if we see at 36 months, 8% of patient was surviving in extreme regimen as compared to 33% patient surviving in patient receiving pembrolizumab plus chemotherapy, highlighting the merit of this treatment and also the sustained benefit, which we want to have more. We want to look data beyond this also, but again reassuring that this treatment does give some long-term benefit for these patients with hazard ratio 0.60 and p-value being significant. If you say the same data for patient with CPS 1% or more than 1%, we have a similar result. The benefit, the proportion of benefit remains similar. The benefit with what we see at 3 years is 25% patients surviving as compared to 33%. But we have known more those PD-L1 marker, it appears more the benefit is, it is not a best marker, but looks like that is what it suggests. But as far as the standard arm is concerned, what we see, that outcome remains similar. So benefit is also seen in population where you have a CPS score more or more than 1. I'm sure what we would have been looking for more about is that what would have happened if the patients were taken for CPS score more than 1 and less than 20%, and then what would have been the outcome. This gives us some hint about it, that if we take patients with all population, and what we see here, the benefit remains, it comes down a bit, but benefit remains in this population also. Pembrolizumab was also the one arm which was compared with extreme regimen, and if we see in the population of more than 20% of CPS score, it remains, it looks like benefit for immunotherapy is similar what we have seen with chemotherapy plus immunotherapy arm in earlier. This becomes a bit tricky when we take CPS population 1% and more than 1%. It comes down a bit, that is the benefit. But again, in this population also, the benefit for giving pembrolizumab remains in this population. But again, I need to highlight, this was not the population where we wanted, that is CPS population less than 20% and more than 1%, that population data to be seen. But again, that's not the data what is there. So what is the final table for this whole trial? If you see this final table and if you focus on overall response rate, pembrolizumab alone, responses are a bit less and we should be careful about it. Again, symptom will decide which one we want to choose. If you take CPS 1% and more than 1%, again, responses less than extreme. And again, that tells us that we should be careful about when we looking for the patients where we are looking for responses in this population. But when we see the overall survival data, and if you see in CPS 20% and more than 20%, then it works and it looks like it is beneficial. 1% and more than 1%, it works, effect becomes a bit lesser. If we take the total population, then effect wanes, and that is where we need to be careful when we talking about single agent immunotherapy in this setting. So what it suggests that more the CPS score, better the benefit is. Are we certain about the score? It looks like 20% is something which we are comfortable about it, but less than 20%, we should be careful about it. Can we have this, the whole trial answer in a slide? This is the, what I can summarize, that if we have pembrolizumab versus extreme and the pembrolizumab plus chemotherapy versus extreme, then overall response rate, no benefit. Progression-free survival in both those group, no benefit. Treatment-related toxicity looks similar, that is reassuring. And especially for pembrolizumab alone, it looks lesser. In CPS score more than 20% or 20%, if you see overall survival, it is superior for pembrolizumab alone, it is superior for combination also. If you take 1% or more than 1%, it is superior for pembrolizumab alone and also superior for pembrolizumab plus chemotherapy. If you take total population, looks like it is not superior for as compared to extreme. But in this study, when we have combined with chemotherapy, it is superior than extreme. with the caveat, as I suggested, the way the analysis has been done, analysis is not that they have segregated the less percent or negative CPS score 0 separately analyzed. They have taken all of them together, and that becomes whatever benefit we are seeing. Is it because primarily driven by high CPS score patients? Coming to oral metronomic chemotherapy, which is something which we work on. It basically means giving lower dose of chemotherapy again and again in a smaller dose. It does have some impact on immune mechanism, and which leads to an angiogenesis, which leads to control of disease. This was our study, a phase 3 randomized trial, where we compare metronomic chemotherapy, which we are positioning here as a immune modulating agent and also as an anti-angiogenic agent as compared to cisplatin single agent. And what it showed that it adds life to the patient, small amount, not as what we have seen with the checkpoint inhibitor, but it looks like it adds life to the patient, easy to give. It also adds quality of life to the patient in this group of population. So another option which is there available to the patient if they want. Coming to platinum refractory disease, we didn't have any treatment before we have this study in this setting, which had proven that it adds life to the patient. And this trial compared nivolumab as compared to any other standard chemotherapy which investigator wanted to give. And this was the first study to show that if you give an immunotherapy to these patients, then these patients, they benefit. The difference in the median survival is small, that 5.1 months to 7.5 months. But the moment we go to 12 months and beyond, we start seeing the difference in the survival expands, and the difference in the survival is as much as around 20% in these patients, which is significant. As far as progression-free survival is concerned, it looks like it benefits a small group of patients. That's why median progression-free survival doesn't change in this situation. But as the curves keep going down, we see that small number of patients, when this drug starts working in those groups, they benefit, and the benefit is sustained in these patients. There's another drug which has been explored in this setting called pembrolizumab with a similar design, and it showed that it adds life to the patient. It did not meet its primary endpoint, which was put in a way for p-value, because p-value was divided for interim analysis. But having said that, by and large, people do consider that it is clinically meaningful, and this drug again remains as an option for treatment in this setting. We have also been exploring our metronomic chemotherapy in this setting, and this was our a study in which was there in JCO some time back, where we used triple metronomic chemotherapy, that is methotrexate, celecoxib, and erlotinib. In this phase 1/phase 2 study, it showed that almost 40% patients, they do respond in this setting. And if we see here, the progression-free survival is around 5 months, and the overall survival in this setting is around 7 months, which is pretty encouraging. And hopefully in future, we will have more data on this. But again, there is an option for patients where they can't take it, checkpoint inhibitor. There's another form of what we position as immunotherapy come anti-angiogenic inhibitor, which people can use it. As far as the quality of life is concerned, as it can be seen in this slide, that it also improved in these patients for FACT-G, FACT-HN, and the FACT total score. This was one of the publication which came in ASCO educational book, which suggested that this is one of those ways one can consider treatment option in this setting, and highlighting that where one wants to choose what, it has become a bit complicated than what it used to be earlier. But again, I say it is always good to have more options than less options in this setting. So you do have extreme regimen as an option, you do have pembrolizumab combination as an option, you do have metronomic chemotherapy as an option, especially in country like ours for our patients, and we need to choose those right patients to give this treatment. What are some data regarding immunotherapy in neoadjuvant setting in head and neck cancer? I have not put all the data, but this is some which is representative. It looks like you have group of patients who benefits, and it appears in this study when they have used neoadjuvant pembrolizumab, it exceeded the upper boundary of outcome for these patients for 1 year DFS as they had thought of when they started this analysis. There's a whole bunch of almost half a dozen trials suggesting that you have a good number of patients who gets major responses and complete responses with having a single and 2 dose of immunotherapy. I think so people are trying to look for what is the best combination. People have also tried combining with chemotherapy, and hopefully in near future we will know that how we are going to take it forward. This is the data based on DFS by pathological response. What it suggests that if you do have pathological response, especially if you do have major responses, these patients, they survive pretty long. Based on these data, there are more than one study, phase 3 study, which is running. This is one representative, which I'm showing that yes, there is an interest in people developing new adjuvant approach for immunotherapy in this setting. What I wanted to bring out that yes, immunotherapy has made a lot of differences in many tumors. It has made a big difference in head and neck cancer because these were the tumors where we didn't have any treatment and nothing used to work. So it looks like there's some places there are some significant outcome improvement in these patients. But there's also some sobering effect, and this was one of the study which was I was eagerly waiting for, and I always thought that most likely it would be a positive study. This was chemoradiation and combining immunotherapy and chemoradiation. But this trial did not show improvement in the outcome when immunotherapy was combined with chemoradiation. We are not so certain about what went, what was the reason for it. As on date, I haven't got a convincing answer from the colleagues from whom I have talked to. But again, people are hoping this is one of those aberration, what we call in p-value, that 0.05. This is being the false negative study. I hope so. There are many other studies which will be coming in this place. One of the studies, I'm part of it. Let's see what the result is. But again, having a sobering effect that it is not easy to do studies, and not necessarily because the drug has worked in one place, it will work in all other places. This is our own data from our immunotherapy experience. I have not segregated for the site-wise, but our initial analysis responses, these are all second line and beyond patients. Responses are around 20%. Major finding is that if you have responses, then the patients do very well. And that's what has been the by and large observation for people across the globe. My acknowledgement from my colleagues who have worked and helped me in whatever data I showed from my side. Majority data was international, but some data which I showed, these are my faculty and these are my coordinators and residents. Thank you so much.
Thank you, Dr. Kumar Prabhash sir, for this wonderful talk. Now I would like to invite our lead discussant, Dr. Raja Pramanik, who is Professor of Medical Oncology, All India Institute of Medical Sciences, Delhi. Over to you, sir.
Thank you, sir. It's always a pleasure listening to you, and you have so well summarized the data which is there in this domain. So, sir, my first question is that how in your clinical practice do you choose the exact first line in a naive patient, in a chemo-immuno naive patient? What factors do you consider and what drug to choose, whether immunotherapy or the extreme? Because many of our colleagues are confused about that risk of progression in the initial phase and the response rates, especially when there is a disease burden high. So what mental algorithm do you have when you choose how to choose these patients?
So, Dr. Pramanik, you made a fair question. What is the mental algorithm? Not evidence-based, but with this data, how I digest it and what I do in the OPD. So, yes, that I'll be saying. So, what I do is PD-L1 is important for me, especially it is important for me by and large everywhere, because my realization is it is a decent marker. It tells you in general what will happen to the patient. It's not an excellent marker. So that becomes very important for me. So if someone comes with a PD-L1 score of 50%, I have no issue at all. I'm not saying 20%, then someone can ask what happens to 19% of CPS and what happened to 21. I'm saying higher, that is there in my mind. If higher, I'm comfortable, that becomes an important issue. Second, the disease burden. Good number of my patients I have seen it comes with some small nodules somewhere. So I know what I want, disease control, but I want a prolonged survival in these patients. With CPS score high and a small disease, it is an easy one for me, because say if affordability is not an issue in these patients. I always add that be careful about patients having symptoms. You do have, these patients are post-surgery, post-CT-RT, they will have symptoms, but more often than not, if it is only a nodule or something, it will be related to those surgery and our chemoradiation rather than the disease. Then it is easy one. Issue is that if the patient is less symptomatic, symptomatic, and the PD-L1 score is low. If a symptomatic PD-L1 score is low, again, it becomes relatively easier. So for example, if I have a big nodes or big soft tissue, pain is there, radiating to the ear is there, patient is not able to open his mouth, move his neck, patient but fit, then again it is easier for me. I choose extreme in that setting, again, if affordability is not an issue in that setting. And again, primarily what you pointed out, that there is whichever way we looks like PD is a problem with this combination. In between it becomes problem, that you have a symptomatic or asymptomatic patient with PD-L1 score being intermediate. So you have a 20%, 19%, 25%, or 15%. Then how do you go about it? In that setting, then it becomes a bit of a lengthy discussion in these patients, and we go choose one or other in this setting. But if the tumor volume is high, PD-L1 score is on the lower side, I end up choosing a non-immunotherapy based treatment in that setting with the bias I have. Now we do have in our population, which I want to add subsequently, good number of patients which can't afford either of them, and then I have my bias for the oral tablets, which we think, especially if the tumor volume is high, my request will be people to choose those triple metronomic. It's only phase 2 data, but whoever has used it, they have always come back and told me, Kumar, this triple metronomic really decreases the size of the lesion well. It is not a sustained response. It will be there for months. It will not be like immunotherapy, but that transient response is very rewarding in that setting. But if it is a smaller disease, then we use the 2-drug metronomic combination in that setting.
Thank you, sir. These are very important lessons for us. Sir, the next question is regarding that Javelin trial. You mentioned that we are expecting that it will be a positive trial, but it became negative. So what, you mentioned that there is no answer, it's probably an aberration of the P effect. But my question is, sir, if we had designed it like the esophageus trial, selecting the patients, would it have been a positive trial?
I suspect that. I think so. They were very enthusiastic, and in fact, what you're saying is that is visible in the trial I'm participating. They in fact especially looked for high risk patient. So I agree that because looks like immunotherapy benefits a small number of people. It benefits in those small number huge way, but it doesn't benefit majority of the patient. Somehow we need to choose those patients, those select patients where the benefit can be maximum. So here it will be someone where you have higher immune response and maybe a higher risk population patients. One may be higher event, but more important maybe higher immune related response to immunotherapy could be. I agree. Esophagus trial, someone may question that you have taken all patients and it would have been useful for everyone, but I think so. Looks like pembrolizumab, they were smarter in lung cancer. The way nivolumab, we all know nivolumab and pembrolizumab, they are a bit different. They have some differential effect, but they didn't choose PD-L1 more than 50, and pembrolizumab they chose more than 50, and looks like it worked for them in a big way. So I do agree with you that high risk patient. And somehow choosing where you do have more immune epitopes there, and that is the indirect evidence. You don't have a direct evidence that immune epitopes are there, but hoping that if there are more tumor, more events has happened, so more hopefully immune epitopes may be there. Yeah.
Sure, sir. Thank you. So that brings us to the question of biomarkers. So you mentioned that PDL1 is a decent biomarker. So what others should we look out in the future? So CTC, ctDNA, will it be helping? What are your thoughts, sir?
At this moment we are stuck with PDL1 in some form, other TPS, CPS, or TC, IC. Somewhere we are stuck with that. One biomarker which looks like useful, which we see in other tumors, especially breast cancer, is a TIL. It can be done in pathology department, easy to do. Someone needs to take it up and validate it. That will be, but hopefully, because looks like again that is something because that you see those infiltrating lymphocytes and say, hey, this is what we wanted to have it. If they are there, hopefully they should be working on it. So maybe that is one area, but that looks like, but biomarker is a problem. The drug is like 1 out of 1,000 comes in the market. Biomarker looks like it's once in 10,000, because I was looking for exome data and transcriptome data in immunotherapy that will get some marker. But we do have some MDM2, KEAP, in lung cancer, but today also people don't decide those treatment based on that, because markers, the moment you start using in multiple labs, you start seeing the limitation of those markers coming up. So as on date, we have not got something like EGFR. We are all looking for something like EGFR and ALK. But at this moment, we are stuck with PDL1. TMB is there, but TMB, they have got approval for pembrolizumab for any patient, but it has been challenged in lung cancer, because when they did a separate work out based on TMB for responses in lung cancer, they haven't got a similar kind of result the way that registration trial was there, where all tumors, all comers were there. So looks like a long way to go before we have some.
Sure, sir. So the next question is about low dose immunotherapy. So any experience with that, sir, if we can decrease the dose, because there is no dose response or dose toxicity relation in these drugs. What is the thought on this, sir?
So we do have some experience about it. We wrote, in fact, this was something we said that we were forced to work on it. We started, because most of our patients can't take it. When we analyze our data, only 2% of our patients can take immunotherapy. In fact, less than that. So we were looking for, is there ways and means to? So there is a biological reason to believe that this dose which we have been recommended, it is not the dose one has to give it. Yes, it does works, we know that, but there's a biological reason for it, because looks like your receptor occupancy almost more than 80%, which is by and large considered to be effective in that setting. It happens that the dose of less than 0.1 milligram per kg for nivolumab, and similar is the truth for, looks like, for other immunotherapy. Then yes, we have been trying this dose of 40, 100, 20, and I can say from the experience what we have in our group, people do respond. Only caveat will be that you don't have a label for it. It is very important to understand that it is the off-label use. It should be on the compassionate basis, and the patient should be aware of. So we document it and clarify to the patient clearly that they have been exposed to all the routine treatment beyond this. They are aware of this. This is not the label dose, and at their discretion, at the and the compassionate ground, yes, we have used it, and I need to say that we have responses. What we don't know at this moment, sustained responses. That we can say after year or two, I can come back and say, hey, what happened to sustained responses? Because we're looking for two aspects. So one aspect, I can say, yes, people do respond. Percentages, please wait, because we need to have some good number. Otherwise, it will be anecdotes. But anecdotes, it does respond. Sustained response, we need to wait for some time.
So I think that was a very nice discussion, sir, and we enjoyed your talk so much. There's a very important practice changing and practice benefiting lessons from that, sir. So thank you so much, sir. Thank you for your.
Thank you, Dr. Pramanik. Always nice talking to you. Thank you so much.
Thank you.
Thank you, Dr. Pramanik. I would like to invite our next chairperson, Dr. Ramesh Nimagadda sir. He is Managing Trustee and Senior Consultant Medical Oncologist from Ramesh Nimagadda Cancer Foundation, Chennai. I request Dr. Nimagadda to provide the session introduction and to invite our keynote speaker, Dr. Vijay Kuchru. Over to you, sir.
Thank you. Thank you. And I want to thank Jyoti and Atul for giving me the opportunity. And this is a great conference. And of course, the new thing about the anti-tumor immunity. And here we have a great speaker, Dr. Vijay Kuchru. He is the Samuel. Can you hear me? Hello?
Yes, we can hear you.
Yes, sir.
Yes, we can.
Okay. Dr. Kuchru is the Samuel L. Washington Professor of Neurology, Harvard Medical School Senior Scientist, Brigham and Women's Hospital and Co-Director, Center for Infection and Immunity, Brigham Research Institute, Boston. And Dr. Kuchru has started his career, has done his degree, bachelor's degree in veterinary medicine from the College of Veterinary Medicine at Husar, India. And subsequently, he has moved on to University of Queensland in Brisbane, where he has done his PhD and also a lot of research. And he is also the recipient of the Nobel Laureate Peter Doherty Lecture Prize in 2014 and so many other lecture prizes. And then he moved on to the US, and there he has been the professor, as I said, and is particularly was interested in the immunotherapy and especially the T cells tolerance and dysfunction. And his laboratory also first described the TIM family of genes and identified TIM3, about which he is going to talk to us today. And he is also has 25 patents and has founded 5 different biotech companies over the years. And with this, I would welcome Dr. Vijay Kuchru. I hope it is pronounced right, to give us a talk on the role of TIM3 in regulating anti-tumor immunity. Dr. Vijay.
All right, thanks very much. Let me take the control here and start my slides. Can you see my slides?
Yes.
All right. Can you see them now?
Yep.
Okay, and you can hear me properly. How much time do I have, Jyoti?
It's a 25 minutes talk.
Okay.
And it will be followed by a question answer session, which will be moderated by one lead discussant.
All right. Okay, thank you very much. Thank you for the invitation. It's early in the morning in Boston, and I have been intently listening to your talks for the last few minutes. I'm going to talk to you about TIM3. And I hope I have, I think I have right talk. I was playing around with the talk. Okay, so it's, even if it says anything here, it's actually on TIM3. So the person who really did the talk is, all of this work was done, Karen Dixon, and some of the other work was by Norio Chihara, Asaf Mahdi, and Madhumita Das from my lab. And on T-cell exhaustion, we have a long-standing collaboration with Anna Anderson and her group. Single-cell genomics was done at the Broad Institute with Aviv Regev and with Matan Hafri. And some of the work and making these mice that we talk about today, some of the knockout mice and knock-in mice were done with Arlene Sharp, and long-standing collaborations with David Hafler and Tomo, who did much of the work in human TIM3. And crystal structure of TIM3 was solved by Rick Blumberg and Amit Gandhi at the Brigham. And just to tell you how I'm going to talk about, I'm going to first describe how TIM3 was described. And that will be the first part of the talk. The second part of the talk is that we find that TIM3, besides being expressed on T cells, may have a very important role in DCs. And third part of the talk would be use of anti-TIM3 antibody in human clinical trials. So as you know, T cell, when they come in contact with an antigen, they activate, expand, and differentiate. They acquire different effector phenotypes. Tim Mossman and Bob Kaufman first described Th1 and Th2 cells. Th1 cells are the ones that produce interferon gamma, lymphotoxin, IL-2, and they are critical for inducing anti-tumor immunity. And Th2 cells are the ones that produce IL-4, IL-5, IL-13, and they're critical for clearing extracellular pathogens, but they are the ones also induce allergy, asthma, and atopy. Since we were interested in autoimmunity, and in fact, I wanted to emphasize all the IO targets we talk about, they all came from people investigating autoimmunity. So Th1 cells were the cells implicated in induction of autoimmunity, and this was before the discovery of Th17 cells from my group and other people around the world. So we wanted to know, how do we identify Th1 cells from Th2 cells? And what we did was we immunized rats with a Th1 clone from a mouse at 5b6 T cell receptor transgenic mouse. And we generated 20,000 different monoclonal antibodies. And Laurent Monnier and Catherine Sabatas with Ed Greenfield screened these antibodies, and we identified 4 different monoclonal antibodies that bound to Th1 cells, and 2 of these were identifying TIM3. And you can see that the antibody that we described was staining these interferon gamma producing CD4 T cells, interferon gamma producing CD8 T cells, but did not stain Th2 cells. And we went ahead and cloned the gene, and this was a novel gene, and this was done in collaboration with Gordon Freeman at the Dana-Farber. And you can see that the gene had a signal peptide IgV domain, a mucin domain, and a long tail, and tail had 6 tyrosines in it. And the humans have about 69% homology with the mouse gene. This gene is located in a very interesting area. It's on towards the centromeric end of chromosome 11 and 5q33 in humans. And both these locations are hotspots for genetic linkage to a number of autoimmune diseases and immune-mediated diseases, including allergies and asthma. I'm not going to talk about that. And there are about 8 members of this gene family in mouse. And somehow there was a reverse evolution. There are only 3 members that are left in humans. And TIM3 is one of those conserved members between mouse and humans. So the question was, what does TIM3 really do? And initially we described its role in autoimmunity. And TIM3 got a second lease of life when Anna Anderson, in fact, started her postdoc in my lab. And I asked her, in fact, to study what's the role of this molecule in tumors. And as you know, that if we take a mouse, we transplant a tumor progressively grows and is not rejected. And then you look at what are the infiltrating immune cells in the tumors. We call them TILs. And she analyzed them. And we can clearly see that there are CD8 effector T cells in the tumor. And when you look at the cell surface expression, and then you see there are some T cells in the tumor that don't express either TIM3 or PD1. And the second set was whether PD1 positive, TIM3 negative, and then you have TIM3 positive, PD1 double positive cells. And you can see that when you don't have any of these checkpoint molecules or co-inhibiting molecules expressed on these T cells, they produce plethora of cytokines and have effector functions. The moment you add on one of the checkpoint molecules, PD1, and they lose some of the functions. And then when you have both TIM3 and PD1 together, and they become terminally exhausted and become dysfunctional, and they can't have any effector functions. And in fact, Rafi Ahmed here in the US was the first one to describe this antagonism between the stem-like cells, which are the ones that respond to checkpoint blockade therapy, and TIM3 expression. So my computational biologist gave them names because she didn't know what to call them. She called them these stem-like cells as mean killing machines. These are the reservoirs that are the precursors for the effector T cells. She called the PD-1 positive cells as wimpy because they still have some functions, but when you have TIM3 and PD-1 together, they are truly dysfunctional. We used to call them co-inhibitory molecules, but the people in oncology and cancer research started calling them checkpoint molecules. And what are the checkpoint molecules? When a T cell is activated, and you need, in fact, two signals. One of the first signals is produced by T cell receptor, and the second signal is induced by these co-stimulatory molecules, and CD1 is the best characterized of all of them. And once the cells activate, expand, and differentiate, then you need to turn them off. Otherwise, every time you have an infection and you get expansion of the effector lymphocytes, and this is the basis for your lymphadenopathy that you see during infection, then you want to turn the immune system off, and you have these series of these inhibitory molecules that come up on the cell surface, eventually getting rid of these effector T cells from their repertoire. But if you get expression of these checkpoint molecules prematurely, and you develop these insert developing effector functions, and cells become exhausted, and these cells eventually produce IL-10, and they become liability to the system. And the question was whether these molecules are co-expressed and co-regulated, and how are they regulated inside the tumor. And we had a paper, in fact, a series of papers in the last couple of years showing that a suppressive cytokine, IL-27, in fact, induces two transcription factors, PRDM1 and CMAF, and these transcription factors will load the promoters of these checkpoint molecules, and these molecules will come together as a module. And it's no surprise. In fact, I'm referring to the talk from my previous speaker who showed that anti-PD-1 or anti-PD-L1 has a limited efficacy in cancer patients. And that's from a really simple fact that it is just one of the multiple checkpoint molecules that are expressed on immune cells or immune effector cells. And there has to be a combination of a blockade that will increase the efficacy. In fact, the PD-1 and CTLA-4 combined blockade shows better results than blockade of PD-1 alone. And this is not only in mouse, that the PD-1, TIM3, LAG3, TIGIT, they all come together in an effector T cell. And in fact, the correlation coefficient of these checkpoint molecules, PD-1, TIM3, LAG3, and TIGIT to come together is 10 to minus 23. So it's not by a chance that they come together. In fact, they are co-expressed, they are co-regulated, and they work together and enhance each other's function. So is this true also in human? In fact, we went through a data set that has been accumulated from human tumors. This is data of the infiltrating T cells from non-small cell lung carcinoma, colorectal carcinoma, melanoma, and hepatocellular carcinoma. There are about 18 genes that are expressed in all of these human tumors, and these are the core signature of these 18 genes. And you can see HAVCR, which is the gene name for TIM3, and TIM3, PD-1, CTLA-4, TIGIT, LAG3 all come together as a module, and TOX is the transcription factor that regulates the expression of these module of checkpoint molecules. So Anna went ahead and did this experiment, is whereby she transplanted the tumor and gave the blocking anti-TIM3 antibody or anti-PD-L1 antibody. And sometimes anti-PD-L1 works, sometimes it doesn't work. But if you co-block both of these checkpoint molecules together, and tumors really melt away, and resulting in the induction of the effector functions in these infiltrating immune cells in the tumor. This is just one example, and much of this data has been published. This is just showing infrared gamma, is that if you don't give the placebo or a control antibody, this is your effector function. And if you give anti-TIM3 antibody or anti-PD-1 or PD-L1 antibody, there is some enhancement of effector functions. But if you co-block both of these checkpoint molecules together, and you get major enhancement of effector functions. So the trick in front of us is going to be that what are the right checkpoint molecules that need to be blocked for each of these tumors. It can't be that we do this empirically, and that's what we are doing right now, is that we have anti-PD-1 and we have anti-CTLA-4. Let's combine them together and test them in in each of the tumors. What we also need, we need the biomarkers to define the series of checkpoint molecule antibodies that we can use. You can see that anti-TIGIT antibody was recently approved for non-small cell lung carcinoma, and similarly, anti-LAG3 has been approved for as an adjunct with the anti-PD-1 for melanoma, and anti-TIM3 antibody is in fact fast-tracked by FDA for approval. So what did I tell you in the first part of the talk is that we have identified TIM3 as a differentially expressed gene between Th1 cells and Th2 cells. And TIM3 comes together with PD-1 to mark the terminally exhausted T cells. This happens to be true both in tumors and chronic viral infection. And in fact, I didn't tell you is that there is this antagonism between TIM3 and stem-like cells, and TCF7 being the molecule that identifies stem-like cells, and TIM3 antagonizes it. And this is the data I didn't show you, is that if we constantly form an active form of TIM3, it antagonizes expression of TCF1, and it also blocks the activity of anti-PD-1 blockade. So some of these data I didn't show you. Safe to say, it's a Th1 molecule that we identified. It's expressed on exhausted T cells. It collaborates with PD-1 and CTLA-4, LAG3, and TIGIT to induce T cell exhaustion. So TIM3 is not expressed only on T cells, even though we spent last 15 years since discovery on T cells. And we made a flux allele so that we can delete TIM3 in each of the cell types where it's expressed. And we went ahead and looked at, in fact, I might go to this. So we went ahead to see where is TIM3 expressed in the tumor mass. And we did single cell RNA-seq, and this is a UMAP of expression of the single cell RNA-seq data sets. And this is showing the tumor infiltrating lymphocytes actually form a different mass than once the T cells coming from draining lymph node or non-draining lymph node. Just to annotate these cells, and this mass is really a B cells. These are DC2s. These are your DC1s. And these are your T cells here. And then we asked them which cells express TIM3 inside the tumor. And what was surprise to us is that majority of the immune cells that in the tumor that express TIM3 are DCs, and the myeloid cells, especially monocytes and monocytic DCs. And these are your T cells and Tregs. You can see the frequency of these cells is very small. So we knew that TIM3 is expressed on DCs from our previous studies, but we didn't realize in tumor mass, these are the major cells that express TIM3. This is just shown at the protein level, and compared to the T cells, the DCs are the major expressors of TIM3. So we went ahead and generated a flux allele, and we crossed it. The flux allele allows you to delete TIM3 with specificity from each of the cell types. So we crossed it onto the CD4 T cell, which deletes it from both CD4, CD8, and Tregs, and we CD11C for DCs, ZBDB46 from specific DCs from macrophages and Tregs. And we can see that the TIM3 is faithfully deleted from these cells when they bred to the appropriate CRE. And when you do a deletion with CD4 CRE, you can see TIM3 gets deleted from CD4 T cells and CD8 T cells, but it doesn't get deleted from DCs. But if you delete it from a CD11C CRE, you can see the T cells maintain it, but DCs do not express TIM3 anymore. So what we did is that we tested these mice. So first one we did is on T cells. And when we deleted it on all T cells, you can see there was a modest effect. These are the animals transplanted with a tumor. There was a modest effect on tumor growth when crossing it to CD4 CRE. When we deleted on CD8 T cells, while we thought it must play a very important role because it's a molecule that induces T-cell exhaustion. Absolutely nothing happened. And if you delete it from FOXP3 positive T cells, absolutely nothing happened. This was a shock and surprise. And then we asked Karen, let's go back to the drawing board and start deleting it from every cell that we find in the tumor mass. And you can see that if we deleted this from all the macrophages, and you can see again, if you delete the TIM3 from macrophages and monocytes, and you see no impact on tumor growth. Disappointed by these results, then there was nothing else left but to delete it on DCs. And what Karen did is that she crossed it to CD11 secrete, and you can see that if the wild type cohort, the tumor progressively grows. But if you delete it from DCs by doing CD11 secrete, there was almost complete inhibition of tumor growth. And then we used other tumors and other Cree drivers that specifically delete the tumor from the DCs, and ZBDB46 Cree is here. And again, recapitulating and confirming the data by using CD11 secrete. This is showing the tumors in the wild type cohort. And when you delete TIM3 from DCs, you have massive tumor growth inhibition. So this is just a comparison. It's showing you that if you delete TIM3 from CD4 T cells, which deletes it from all T cells, because during thymic development, when the T cells go to thymus, they express CD4 plus, and then it allows you to delete it from both, not only from CD4 T cells, but also from CD8 T cells and Tregs, and delete TIM3 from all T cells. There's a modest impact on tumor growth. And if you delete it from DCs, and you can see the massive inhibition of tumor growth, and the tumor sizes are shown here from one of the experiments. So what does it do? So we went ahead and looked at the T cells in these mice. So here we have, as we have deleted TIM3 from DCs, and tumors show tumor growth inhibition. Now we are looking at what happens to the effector functions of DCs. And the very first thing that you see is that the cells that are co-expressing PD1 and TIM3 are decreased in numbers. Instead, you have the induction or expansion of the PD1 single positive T cells, and which retain effector functions and are not terminally exhausted. And it's shown numerically here is that there's a biggest drop is in loss of exhausted T cells, and you have expansion of PD1 single positive cells. And these are the PD1 single positive cells that are significantly producing effector cytokines and retaining cytolytic effector functions. So we also went ahead and looked at each of these cells. So you don't have to believe me, you can look at the data. So let's look at these PD1 single positive cells that are present in the conditional knockout mouse. And you can see that these single positive cells are maintaining TBET, which is a transcription factor that induces infront gamma. They are still proliferating. You can see they express Ki67. What's also interesting is that they have these transcription factors that maintains the stem-like signature, stem-like behavior, something that Rafi Ahmed, in fact, described. And they are the ones that are responding to cancer immunotherapy with anti-PD1 blockade. And what I told you already is that there is decrease in these terminally exhausted T cells. And here we have TIM3 is not being deleted from T cells, but we are deleting it from DCs. And we're seeing these massive effects in induction of IL-7 receptor. And there's a decrease in other checkpoint molecules, CD160, which also comes in during terminal exhaustion. So deletion of this checkpoint molecule, we allow in our lab, we described it and discovered it and to be expressed on T cells, and its deletion on T cell does not have such an effect, but if you delete it from DCs, it has major effects on expanding effector T cells. So the question is, how do we put these two things together? That on one side, we are in fact deleting this molecule from DCs we are reading the effects on effector T cells. And for a long period of time, we actually had no idea. We did not know how to identify what DCs are doing to T cells to induce tumor regression. And we finally used a piece of algorithm that was written at the Broad Institute with Eric Lander and Aviv Regal called Waddington OT. And there's a small piece of algorithm that looks at changes in receptor-ligand interaction, and we applied it to the tumor, DCs plus T cells, to identify what's so unique about the DCs that don't express TIM3 and what goes up, which is different between the wild type cohort versus the one DCs when the TIM3 is deleted. And one of the things that came out is that there is an enhanced signature for IL-18, which is shown here. And this IL-18, as you know, is one of the cytokines produced by inflammasome. So we then went back and looked at inflammasome signature, and I can show you in a minute what inflammasome is. And these are the components of inflammasome. This is AIM2, NLRP3, caspase-1, IL-1, IL-18. These are all the components that form these inflammasome. And you can see inside the tumors where DC had a deletion of CD11C with CD11C CRE, you can see the inflammasome signature was increased. So you may be wondering to yourself what inflammasome is. It's a multimolecular complex that allows you to release IL-1 and IL-18. I have a slide just showing it. And you can see immediately that in the DCs where TIM3 has been deleted, there's an increase in both IL-1 and IL-18, but there is no difference in IL-12, which is induced by TLR signaling. So somehow, deletion of this checkpoint molecule from DCs is inducing massive effects on tumor growth retardation and resulting in inflammasome activation. So what is inflammasome? Inflammasome is one of the systems in innate immune system to activate production of IL-1 and IL-18. And in fact, it's a multimolecular complex where the signal 1 by TLR induces all the components, transcriptionally all the components of inflammasome, NLRP3, AIM2, NLRP1. And then this is the signal 2 when it's bound by bacterial products, or even products like products that are activating this induced during stress, like gout crystals. It will activate this, make this multimolecular complex activate caspase-1 and induce IL-1 and IL-18 and form these pores through which IL-1 comes out. So the question was, can you have an effect on abrogating the protective effect? So I showed you this data, is that the deletion of TIM3 from DCs has a massive inhibition of tumor growth. And if you give inhibitors of NLRP3, like CRID3, it will abrogate the protective effects we observe in the TIM3 knockout mouse. So we have used multiple different inhibitors of inflammasome pathway.
So 1 minute left, sir.
Okay. All right. I guess you will not see the clinical data then.
You may continue for 2-3 more minutes if that will help in conclusions. We can cut short the time from the discussion, Rekha.
Noted,
Okay.
ma'am.
Please go ahead.
Okay. So if you block this pathway, CRD3, which blocks NLRP3, you can see abrogate protective effects. If you block caspase-1 inhibitor, you block this protective effect. If you block both this, if you block both IL-1 and IL-18, and you can, in fact, abrogate the protective effect. So if you get rid of this checkpoint molecule from DCs, what you do is that you activate inflammasome, and this activated inflammasome is inducing more effector T cells. So in the wild type mouse or in human being, TIM3 is expressed on DCs in draining lymph node. It is a receptor for phosphatidylserine, and it inhibits the anti-tumor immunity. And if you don't have TIM3 on the cell surface, the DCs get activated, inflammasome gets activated, and it induces the production of IL-1 and IL-18 through pyroptosis, and enhances and activates innate immune system, and resulting in the enhanced effect of T cell functions. I'm going to quickly actually go through. I don't have enough time. I apologize. I was probably describing too much of the data. Is that the anti-TIM3 antibody has been used in clinical trials. In fact, its effects in combination of PD-1 is already being evaluated in phase 3 clinical trials. There are 12 different clinical trials. But one of the interesting features is that the TIM3, since we've found that it's expressed on myeloid cells, it was used in acute myeloid leukemias, because in acute myeloid leukemias, the stem cells, the cancer stem cells express TIM3. So this is a clinical trial where the patients were given a decitabine with anti-TIM3 antibody, which is called MBG453 or MBG5453 alone. And then they were looking at both the maximal tolerated dose and efficacy. And I'm going to summarize the data. Is that the clinical trial has shown that if you block anti-TIM3 with hypomethylating agents, and they are almost complete responses that you see in about 60% of patients, and they are not only in effects in the blood-derived myeloid cells or myeloid tumor cells in acute myeloid leukemia and myelodysplastic syndrome, but you also see effects in bone marrow of these patients. And if anybody wants to ask me questions about it, I'm happy to talk about it. And just to summarize the data set, what I showed you is TIM3 plays an important role on DCs to regulate anti-tumor immunity, and a deficiency of TIM3 on DC enhances cross-presentation and induces stem-like behavior on effector T cells, such that these DCs inducing these effector T cells can really induce anti-tumor immunity. And one of the things that we identified is that TIM3 is a checkpoint molecule also for the myeloid cells, and it blocks the activation of inflammasome and production of IL-1 and IL-18, thereby it inhibits anti-tumor immunity. And the preliminary data, in fact, it's not preliminary anymore, is that they suggest that it may be one of the therapies that's going to be approved by FDA, because it has been given the fast track status by FDA for approval, and it has been also given an orphan status for therapy for AML and MDS in Europe by EMA. And this is my lab, and we have a soccer team, and this is our fearless captain, is Alex Schnell. And I have been looking for good soccer players. If there's anybody in the audience, please write to me. I thank you for your attention. I apologize, I took a little longer than I should have.
Thank you very much.
All right.
I request our lead discussant, Dr. Sunil Arora, sir, to moderate the question and answer session. Dr. Sunil Arora, sir, is the President, Indian Immunology Society, Head Department of Translational, and he's the Head Department of Translational and Regenerative Medicines from PGIMER, Chandigarh. Over to you, sir.
Thank you, Rekha. Thank you, Dr. Vajpayee. And it was an interesting talk, and I couldn't miss the opportunity to listen to Vijay again on TIM3. He has elaborated today a little bit more, where he has shown that TIM3 is more expressed on dendritic cells rather than on CD8 cells and CD4 cells, and its effect can be seen if you block TIM3 expression on dendritic cells. So that is a wonderful, finding, because he has shown its, role in tampering with the inflammasome, and that's something new. So we have some questions, Vijay, for you. on the chat box. The first question we can see on this is by Dr. Raja Pramnik. GP has not been proven to predict responses of, are these for him only? No, I don't know. There are some questions, other questions which have not been deleted earlier. So let me see. Yeah. So we have Dr. Girdhari Lal asking, what about effect of anti-TIM3 on effector and cytolytic functions of NK cells? Since you have shown dendritic cells, CD8 cells, CD4 cells, but you have not talked about these NK cells.
Yeah, so TIM3 is expressed heavily on NK cells, and there are a few papers showing that if you block TIM3, it can also enhance effector functions in NK cells. There were 3 papers that came together 3-4 years ago, and one of the papers showed that it doesn't have any impact at all on NK cells, but 2 other papers showed that the TIM3 is also an inhibitory molecule in NK cells, and it enhanced the NK cell function. And but in our fluxed allele, when we deleted TIM3 from the NK cells using NK cell 3, we didn't see any effects.
Okay. So another question is from Amit only. He is asking, what is the role of FOXP3 Tregs expressing TIM3 in tumor?
Yeah. So I may have actually, I must emphasize, when I give this talk, people think that the TIM3 has no role on T cells, and that's not true. In fact, if you look at T cells alone, it induces T cell exhaustion. And it's also heavily expressed, what Amit asked is actually a good question. It's heavily expressed on Tregs that are expressed in the tumor mass. And Anna Anderson, when she was in the lab, and now she has her own lab, she deleted TIM3 from Tregs, and it looks like that when you delete TIM3 from Tregs, you can't set up the state of T cell exhaustion inside the tumor. And it was actually very clear that it has a very important role in regulating and enhancing the Treg functions. You get rid of TIM3 from Tregs, and they become unstable, and the Tregs start producing interferon gamma and TNF, and they look like they are effector T cells. So TIM3 is essential for stability of Tregs inside the tumor mass.
So do you think it has some role in the myeloid-derived dendritic cells as well? The myeloid-derived suppressor cells, sorry, MDSCs.
Yeah. So good question again. We think it does have a role in MDSCs, but we don't have, and nobody has. You see, the MDSCs, if you really look through the literature, it's hard to put your fingers on it and do definitive experiments to delete it from MDSC. There is not a driver that clearly defines MDSCs, but it is expressed on MDSCs, and it may be playing a role in their function, but what function it does, I do not know.
But the question is, if you delete this TIM3 in the dendritic cells, so what happens to these MDSCs or Tregs?
So if you delete it in TIM3 on DCs, the MDSCs frequency and numbers go down as well. And Treg numbers go down as well.
Okay. So there is another question. What about effect on anti-TIM3 therapy in cold tumors? Cold tumors.
Yeah. So the cold tumors, what the Rahul is, so I'm just reading it. This is from Girdhari. The cold tumors are where you don't have any infiltration of immune cells. And we have not as yet specifically looked at the cold tumors, either in the mouse or in the humans. It would be some of the pancreatic tumors where we find that these tumors are cold, and some of the human tumors. And once the antibody gets approved, it will give us an opportunity to test this antibody in other tumors where PD-1 alone does not work and the tumors are cold. I do not know the answer.
So Rahul is asking, are there any clinical trials open in India as well?
None that I know of. In fact, Biocon at some point was thinking of making an anti-TIM3 antibody. And as you know, it is heavily protected by IP. And currently, Novartis has an intellectual property that's controlled anti-TIM3 antibody. So at some point in time, I think some of these big pharmas will do clinical trials on anti-TIM3 in India as well. And I'm pushing for it. So hopefully we can do this in some of these tumors that are prevalent in India.
So we have only a couple of more questions. I think we should take them. They are good ones. So one is from Neha Patel.
Sorry to interrupt the session. Actually, our other all speakers from different zones. So I know they are very intense questions and everybody needs answer. Can we request Dr. Kuchru to please answer the remaining questions in chat box, and so that we can move on, within time. And I'm extremely thankful to you for this wonderful talk and very intense discussion, very thought provoking. We'll be in touch for near and far future, certainly. Thank you very much.
Thank you for the
very much,
invitation.
Dr. Sunil, for this moderation of question answers.
All right.
Thank
Nice
you.
to see you. Nice to see you, Sunil. Nice to see you, Amit. Wonderful.
Yes. Good.
Take care.
It's always a wonderful talk. Thank you.
And we can continue our discussion in chat. So request everyone to be there. And
okay.
Over to you for next session, please.
So much, sir. Our next chairperson is Dr. J.P. Agarwal, sir. He is professor and head department of radiation oncology from Tata Memorial Center, Mumbai. Due to some emergency, Dr. Rajesh Mistry could not join us. So I request Dr. J.P. Agarwal, sir, to invite the next speaker. Over to you, sir.
Good evening. I know we are running a couple of minutes late. I will try to do the justice for this talk. And to introduce the topic, we will be discussing on the immunotherapy of the lung cancer, the paradigm shift of palliative to curative setting. I have known Professor Peters since quite some time. She has, to introduce her, it is quite a bit honor. Professor Peters did her MD and PhD from medical school at University of Busan, a beautiful city and hosting IOC. She subsequently completed her residency in internal medicine, and then she was one of the best European candidates when she completed her ESMO oncology training, and simultaneously she did from the Switzerland Oncology Society too. And besides, she is a great human being. She is really passionate about the patient care, and in the multimodality forum, she is a great leader, and she moves the thoracic medical oncology systems in a department of oncology at Busan. And she is building a strong translational research program there, and she's doing with several universities like Ludwig Institute and so many others. She is a real achiever. Let me say that. She is building big trials and platforms, and she not only does that, she is a very avid administrator, and she is one of the few members that she's working in ISALC, European, and she is a real mover for the Women Championship in medical oncology. Besides teaching, she is an avid writer. She has more than 250 publications in her credit, and she is an editorial position, a very senior position in both JTOs, Frontiers, and so many thoracic oncology groups. And it's a pleasure that she is the current president of ESMO. I invite her to give her a talk on the immunotherapy of lung cancer, the paradigm shift from palliative to curative setting. Professor Peters, the podium is yours.
It is my great pleasure to be here with you today and to discuss the paradigm of immunotherapy for lung cancer, which has made us think about going from a palliative setting in advanced non-small cell lung cancer to a curative setting. This is my disclosure slide. First, and to start, I just would like to emphasize this specific need we still have to define biomarkers for immunotherapy. While we have major hopes about potentially long-term benefits and even cure of some patients, we still have difficulties in defining who are the patients who have an IO sensitivity on the left or an IO resistance on the right, meaning we still are unable to find these biomarkers which really help you deciding for which patients, for which treatment. I will talk in this specific session about what we know in terms of selection processes, but also about everything we still don't know. But to start this talk, it's not difficult to say that hopes have been created because the bar was very low. Look at advanced disease where long-term survival in non-small cell lung cancer was simply never observed if you think about the chemotherapy timing. And of course, the bar was very low. It's not against or despite the fact that we have been trying to improve this outcome, but whatever regimen of chemotherapy was used in this landmark publication, you can see that the median OS was 8 months, and that every chemo was giving rise to the same activity, and the only limitation and maybe the only difference was a toxicity profile. So basically, a long way to go. In immuno-oncology, in immunotherapy, we always pretend having made very numerous advances, I would say. We have to keep in mind and stay modest, telling that we just started 2 synapses, one during the priming phase, the CTLA-4, and one during the effector phase of the immune response within the tumor, so PD-1, PD-L1 signaling pathway. But what is interesting is the growing numbers of drugs, EP, tremelimumab for CTLA-4, but you have this growing number, and it's good to have the names here for you, of anti-PD-1 or anti-PD-L1, which probably don't change so much the use and the activity of what we do with IO, but I hope in the future will increase the accessibility to this compound around the globe in terms of sustainability and cost, of course. When you look at all these antibodies, and here I just wanted to make you a comparison, keep in mind that they are not the same. They have different half-lives, different volume of distribution, different occupancy of PD-1, different IgG FC modification, meaning they bind differently to Fc gamma receptors, which are many, so inducing a different cell cytotoxicity. All of this differ from one to the other one. But I must also admit that today it did not translate into real efficacy difference. In the patients, it's very difficult to see differences in the outcome. And this is a table. I just would like you to have this slide if you want to know a bit more about these Fc gamma receptor differences, which are really making the difference between these antibodies. It's very theoretical, but it's very useful. Keep it in mind and go quietly through these differences in how you can induce a complement-directed cytotoxicity or antibody-dependent cell cytotoxicity. But just to speak about immunotherapy, like every new strategy, we started in 2015 only with late lines, of course, outside of the standards of care, moving interestingly to frontline in selected patients, and as you know, also now moving to early disease in the context of neoadjuvant or adjuvant immunotherapy. So very important move for IO. But we speak today about advanced non-small cell lung cancer. So if you think about advanced non-small cell lung cancer, you have this triangle telling you what are the options you might choose. Immuno only, chemo IO, or IO-IO. So when do you use IO only, which we all would love to do? So very importantly, in lung cancer, we have almost established the PD-L1 expression measurement and analysis on tumor cells, looking at various assays, which are almost superimposable, showing the continuous variable, the continuum, and also showing that you can use cytoblocks to measure PD-L1. So very interesting data, which were very useful for us, because now, based on the ROC curve of PD-L1 and pembrolizumab usage, we could define this threshold of more than half of the tumor cell expressing PD-L1 with this very massive benefit of immunotherapy on the top pembrolizumab versus chemo in more than 50% PD-L1 with a doubling of the 5-year survival up to 32%, and very nice confirmatory results, which is always comforting for the oncologist, on cemiplimab Same hazard ratio, shorter follow-up. Be careful, this trial was only performed in smoker patients, meaning that maybe it's even slightly better in terms of results. And on the right-hand side, atezolizumab monotherapy with maybe some dilution, and as you can see, it's not significant anymore because in the hands of Genentech and Roche, they also look at immune cell, which probably don't have so much of a predictive value. But data superimposable, comforting in that sense. If you look at the 5-year KEYNOTE-24, the upper panel, keep in mind that still we need to make some progresses. In that trial, all the patients stopped pembro at 2 years. And if you look down the road, 1 year after stopping pembro, the good news is 81% of these patients are still alive. So 19 died after stopping pembro, which is still acceptable. But if you look at the table and the little line, when they stop pembro with the disease controlled at 2 years, 54% of them will progress in the next year. So what about continuing? What about having better immunotherapy? I think we still need better immunotherapy. About more than 50%, there was another trial I will tell you about in two words. It's this attempt to combine pembro and EP in the more than 50% PD-L1, okay? This was the KEYNOTE-598, which was stopped based on the Safety Monitoring Committee recommendation for potential futility, and the patient had to stop ipilimumab and continue only with pembrolizumab. So very importantly here, the problem is probably that the trial was stopped before the, I would say, expected inflection point of the curves. So, of course, no real benefit was seen in this more than 50% PD-1, but maybe the EP was stopped too early to see, like in melanoma, at some point, a late benefit. But just to contribute to the data set. 50% is a threshold. We knew it from the ROC curve, but we know it also from clinical trials. 5% threshold with nivolumab is not good. 25 with durvalumab on the left in MYSTIC is not good. 1 to 49 in KEYNOTE-42 with pembro is not sufficient. And any other level with atezolizumab is not sufficient. So the threshold is correct and is accurate in defining this subgroup. It is a continuum. On the left-hand side, these American colleagues have shown us that the more the best. So the 90 to 100% do better than the 50 to 89. And on the right, it is the semiplimab trial I have shown before, when you can see this incremental of PD-L1 being correlated with incrementals in OS and PFS. So very interesting data. Keep in mind that we love to prescribe monotherapy IO because there is a low level of treatment-related adverse events, and particularly of high-grade treatment-related adverse events, where you have to keep in mind something like 20 to 30% of grade 3 to 5, which is very acceptable for patients. Plan number 2, if you don't have a high PD-L1, and what do you have for the all-comers? So the all-comers have benefited from many trials, and these trials were comparing chemo IO versus chemo. 3 of them have come out being positive in non-squamous non-small cell lung cancer. Pembrolizumab, atezolizumab plus bevacizumab, or atezolizumab with a backbone of nab-paclitaxel. So 3 trials in green can be used now in many countries in non-squamous non-small cell lung cancer. The most used one is pembrolizumab plus chemo versus chemo. This is a 3-year outcome. You find again this 30% at 3 years. Remember that monotherapy with pembro was 5 years, 30%. So slightly worse, but probably because you can see this benefit being stronger in high PD-L1, becoming a little weaker in negative PD-L1. So it is valid across all PD-L1 strata, but keep in mind that, of course, the highest PD-L1 is the best. So this is one of the strategies. I know your question. So what are you going to do in more than 50% PD-L1 patients? Chemo or chemo IO? So we tried to ask this question across clinical trials, but no pharma industry wanted to support a trial comparing their compound with their compound. It would not make sense. So the only way to have an answer to that question was for the first time to do a Flatiron. It's a huge database, you know it, real-world evidence analysis. And starting with 250,000 patients, and making very sure that the patient were fulfilling all the requirements of a patient naive for treatment, high PD-L1, no driver, PS0 to 1, good laboratories, all of that, we end up being able to compare 351 patients with high PD-L1 receiving monotherapy to 170 receiving chemo IO. We did this adjustment, which is a kind of stratification retrospectively, what we call propensity score weighting, and we looked at survival. This was a design, but the result is simpler. The result is, if you look at the adjusted or unadjusted analysis, in more than 50% PD-L1, chemo IO performs as well as IO mono. And this holds true for PFS, and this holds true for patients with or without brain mets, with or without liver mets, but this does not hold true in patients who are never smokers, because never smokers need chemo, probably because they have a polyimmunogenic tumor, and you can see this hazard ratio of 0.25 in favor of the combo of chemo IO. So never smoker, high PD-L1, you need to give chemo. Of course, if now you try to pile up this data about more than 50% PD-L1, and just to give you a real feeling of this subset of patients, right? You will see later on, but this is on the left, Nivo-EP. On the right, it is Pembro mono. Look maybe at 2 years. At 2 years, you really have the same kind of number of survivors. So it's survivors, it's independent of the follow-up, so very similar results. If you look once again at 2 years of the Checkmate 9LA on the left with chemo and EP and Nivo, 45%, and on the right, our real-world evidence data. So the question is, maybe in more than 50% PD-L1, chemo might not be needed. And that's the main conclusion of that trials. And by the way, it was also supported by this Cochrane meta-analysis, which was looking in high PD-L1 of chemo versus chemo IO, and found it was equally efficacious and active. I was thinking about this chemo IO story again. We have one positive trial of chemo IO versus chemo in squamous, because now we speak squamous, and you see in squamous, it was again the pembrolizumab with a backbone of taxane and platinum, right? This is the curve. Of course, it's squamous, so the outcome is slightly worse, but at 3 years, you have 30% versus 18% survival, and a signal showing that it can be used across all strata of PD-L1, but you will agree with me that the numbers in negative PD-L1, as well as the hazard ratio, are slightly disappointing. We need better options for negative PD-L1 patients. And this is where the ESMO data come in, and the ESMO data is about these new antibodies too. And here we think about the cemiplimab, this new anti-PD-1, and the trial was performed very confirmatory and presented at the ESMO meeting. All advanced and naive patients, no driver, stratified by histology and PD-L1 level, less than 1 to 49, more than 50, and being randomized between cemiplimab plus chemo versus placebo plus chemo. What is interesting is all histologies, right? Okay, and the primary endpoint is OS. So very representative data, very similar to what we have shown. We are reassured at that ratio 0.71, and you can see at 1 year a very significant 10% difference survival, and this non-proportional hazard ratio. So very confirmatory data with cemiplimab. This holds true again all types of patients, including patients with brain metastasis, including patients with all kinds of histology. However, histology is not a factor. But maybe something to look at is the negative PD-L1. Again, these negative PD-L1 patients deserve to have better treatment options than this one. Okay, let's look at this trial and look at toxicity. So now grade 3 and 5 is not only 30%. Suddenly, it's between 60 and 80 plus. So giving chemo IO is not trivial in a patient, and if you could avoid it, it might be better. Last but not least, IO-IO and IO-IO chemo. I don't want to spend too much time on this very complex trial, but Checkmate 227 was 2 trials in one. One was focusing, one stratum was positive PD-L1, the other stratum was negative PD-L1, and Nivo-EP was compared to chemo. And in both strata, there was an experimental arm, an exploratory arm, Nivo mono for positive PD-L1 and Nivo chemo for negative PD-L1, but this was really exploratory. And I would like you to look at Nivo-EP versus chemo and look at the survival. So unfortunately, at the time of trial design, we decided that maybe the best luck we had in showing a benefit was PD-1 positive patients, which now is shown to be wrong because EP can change the status of PD-L1. So you can see the primary cohort endpoint is this positive PD-1 patients. Nivo-EP is better than chemo. And you can see here with the 4 years follow-up that it's a nice difference with a nice hazard ratio of 0.76. But if you look at the secondary endpoint, I would even say exploratory negative PD-1 cohorts, you see an even better hazard ratio of 0.64. And believe me, the Nivo-EP arm is exactly the same. What changes in patients with negative PD-L1 here is the chemo arm, which is moving down. So basically, Nivo-EP is an option across histologies, but by protocol in positive PD-L1. So that's what we had for the 227 Nivo EP. It's important again to say that it remains valid across histologies, right? And there might even be some signals that in squamous patients with negative PD-L1, it is the right graph, on the bottom, they show the best benefit. This patient for whom nothing works, right? Negative PD-L1 and squamous, they do particularly well under Ipi-Nivo, but this is very exploratory. And last but not least, it's very, you can criticize really this analysis, but in patients who had to discontinue all components, meaning Nivo and EP, if you plot their survival curve from the randomization time and you look at their survival, this is a dotted line that you have here. It's important to say that these patients who had to discontinue don't have a worse OS. They have even a median OS, which looks like quite nice if you look at the table on the right. And very interestingly, they have a quite long duration of response after discontinuation, up to 5 years. So the conclusion is not that you can compare this patient, and this graph is betraying you, but just to tell that if a patient has to stop for toxicity, it doesn't mean for the patient that the survival will be poor or that the survival would even be worse than the one who don't stop the treatment. This is good news. What about chemo IO? So here comes a 9LA. 9LA was built on 227, but cleaner. 9LA also is building with a short course of chemo. We just want to create this immunogenic cell death. So it's 2 cycles of chemo with Nivo EP. Remember, EP is low dose in lung cancer versus the usual chemo plus maintenance pemetrexed. So patients are naive patients, no driver, stratified by positive versus negative PD-L1, sex and histology. Primary endpoint is OS. So very straightforward trial, short course of chemo and Nivo EP. And you can see that one thing which is good is for the first time, we don't observe this crossing of the curve. So all patients benefit from the beginning, which was not the case for 227, for example, or the monotherapy trials. And as you can see here, the hazard ratio is 0.72 with this nice plateauing of the Nivo EP chemo, making 9LA another treatment option. This treatment option was valid, interestingly, across all strata of PD-L1, including the negative one. Remember, when you give EP to a tumor which is negative in PD-L1, there's a high probability it becomes positive in PD-L1 due to an interferon gamma signature. So that's maybe a way to revert a negative PD-L1. And the other interesting data set is this huge benefit you observe in patients with brain metastasis. In that trial, they were treated and asymptomatic, but you also had this incremental of efficacy in 227, just showing that brain mets and negative PD-L1s might be good patients for CTLA-4. And here you have PD-L1 negative tumors, and you can see here, and for the first time, an amazing duration of response and very nice OS and PFS curve, really arguing for the CTLA-4 component. What about safety? Well, you are middle way. Only 2 cycles of chemo make you not 30, but not 80%. You have something like 40 to 50% grade 3 to 5 toxicity with this short course of chemo. There are other trials I don't want to stop on with this dual immunotherapy, the Mystic trial, which was negative, but give us some thought about TMB. But it was basically a negative trial and was focusing on patients with more than 25% PD-L1. So Neptune, it was focusing on high TMB, more than 20 mutations per megabase, where the OS endpoint was not met. We still wait to see these results. And the BR24, which was interesting, it was durvalumab versus durvalumab plus chemo, and here chemo did not bring anything. So very nice data. Remember this interesting TMB data from Mystic. When you have a high TMB, it looks like durvalumab makes better than durva, which makes better than chemo. That the CTLA-4 component might even be more efficacious when you have a lot of mutations, lots of neoantigen to be presented. But this was, of course, exploratory. And this brings me to ESMO again and WordLong, where this Poseidon study was published first at WordLong, where it's a trial comparing durva plus chemo, durvalumab plus chemo, or the platinum-based chemo. So very complex design and also very complex treatment with 4 drug regimen, stratification by PD-L1, more than 50 versus less than 50, disease stage and histology. Also, the statistics were very complex. You can see that most of the alpha has been given to durva plus chemo versus chemo, following the other trials published like Keynote 189 and 407, right? And you can see here that this was the alpha given there. So down the alpha or durva plus chemo versus chemo, you had durvalumab plus chemo versus chemo for PFS, but the OS was not met for durva plus chemo versus chemo, so the OS could not be immediately circulated. So we have only 1% alpha for the durvalumab plus chemo versus chemo. You will see really now why I speak about that. It's important you know and you have this scheme with you. Durva plus chemo versus chemo. Well, you can see here that it meets PFS endpoint, right? But it does not meet the OS endpoint. So it improves PFS and not OS, which will probably classify this treatment option in the range that usually we call not to be registered because we have other options in the exact same setting. What about 4 drugs? So the 4 drugs, and despite the fact that the alpha has been sacrificed somehow in the statistical design, durvalumab plus chemo versus chemo meets PFS and OS. So important statistical difference with hazard ratio of 0.72 and 0.77. And as you see also a quite nice 2 years probability of overall survival. However, remember also it was a secondary endpoint. So we have to see how this will be evaluated by regulatory authority. In terms of patients, it's interesting again to see that durvalumab and chemo correct for the negativity of PD-L1, again showing that maybe the CTLA-4 component is an important one. Otherwise, there was no real meaningful subgroup benefiting differently. This is the current algorithm for you with all the new trials. High PD-L1, Keynote 42, Keynote 24, IMpower 110, Empower Lung 1, all monotherapy options. And then you have this chemo IO, IO-IO, or IO-IO chemo, like checkmate 9LA and poseidon. So we have too many options today in the frontline setting. Of course, I haven't spoken today about all these new components, right? It's just to tell you that there were also trials I couldn't evoke here, which use this new anti-PD-1, anti-PD-L1. You can see here camrelizumab, sintilimab, tislelizumab, which were all also positive, showing a new market and new opportunities for this drug and confirming what we know. And the last slide is upcoming phase 3 trial. How are we going to move? You can add a PARP inhibitor, olaparib or niraparib. You can add a VEGF receptor inhibitor like lenvatinib. You can add TIGIT, and you can add, for example, the anti-IL-1 beta, canakinumab. All these trials are ongoing frontline to build on the chemo-IO combination and get better results in the future for our patients. And with this, I thank you for your kind attention.
Thank you, Professor Peters. It was a wonderful talk, and I would like to thank the organizers for giving me this opportunity to be with you. And I request now Ullas, my great friend, to lead the discussion on this. The opportunities are really becoming big for the lung cancer patient, which was
that was fantastic. I mean, that was power packed, as power packed something which in 25 minutes can be. Thank you, Professor Peters, for a wonderful exhibit of overview of immunotherapy in non-small cell lung cancer. It's my proud privilege to ask you certain questions. And my first question to you, Professor Peters, is you started with biomarkers in non-small cell lung cancer. So, 2 years back, there was a whole lot of hoopaloo about TMB, and then suddenly TMB faded away. PD-L1, imperfect marker, but that's the best one that we have. What is your opinion about if you have to place your money on the next biomarker, which one will you tell? I'm asking you an inside story, inside question.
Yeah. So I agree with you. PD-L1 must be used because it's now well established. It has flaws, right? It's dynamic, it's heterogeneous, but we know how to use it. TMB is a good biomarker. However, we were never able to standardize it. And now we realize that it might have to be corrected by the amount of DNA and the accuracy of the measurement, corrected by the type of mutation you look at, single nucleotide variant, or also indels, and probably also corrected to the loss of heterozygosity of your HLA composition. And only if everything is corrected, TMB might be used as a surrogate of the presence of neoantigen. So probably TMB will never be accurate enough to be a strong biomarker for all clinical trials. So two biomarkers for me might appear. First of all, of course, the V2.0 of TMB, which is neoantigen. You can have good algorithm, and they are better and better predicting what mutations give rise to strong neoantigen, and you match it to the AGLA composition of your patient. You will tell me it's very expensive and long, but remember we were telling the same 10 years ago about sequencing, and now we sequence. So it's about new technologies they can. So the second biomarker I might bet on is what we call the immune gene signatures. Remember, we have been trying in lung with 20 RNAs being looked at for quantitative analysis, but now we start to know which one. And for example, at ESMO for mesothelioma, we looked at many biomarkers. The only one which was powerful was a 4-gene expression patterns, immune gene signature. So we might be able to describe the microenvironment and the pre-existing immune response by looking at the right set of immune genes. So I hope it's going to be a simple test, like a chip, right, that you could use to do that. And we are exploring that.
Okay. Do you think there is any point in doing a liquid biopsy prior to doing immunotherapy? Where do you see the state of liquid biopsy as far as immunotherapy is concerned?
Yeah. So liquid biopsy can be used for most of the things I speak about, including the TMB, for example. The only problem you still have in lung cancer is keep in mind that 15 to 20% of the patients are non-shedders. So everything you define in the blood has also to have an equivalent in the tissue, which is methodologically not always easy. But I guess we will use liquid biomarkers, even for immune gene signature. We struggle a bit more with RNA, but we can do that. So time after time, we will use that. The only problem, of course, will be these non-shedders and to standardize these technologies. So there's one thing we very often speak about is how circulating biomarker might be prognostic or predictive, or even pre-announce a relapse with minimal residual disease. So we are also moving in starting to detect if the tumor is still here or not by looking at the blood. This is very expensive. You need private signatures of the tumor to be very sensitive and not having false positive patients. But I think in the future, we'll even be able to predict the outcome of patients, or at least the relapse, and maybe predict the efficacy of a treatment by looking at what is circulating and how it evolves over time.
So do you think, you spoke about the MRD status, Dr. Sorange. I mean, do you think with expensive drugs as osimertinib in ADAURA and Empower 010, do you think MRD will play a huge role? Do surgery, do 4 cycles of chemo, do an MRD. If you're negative, probably not give osimertinib. I mean, do you think there's a role of doing MRD?
It will play a huge role, I'm sure. It's a setting, like you say, of minimal residual disease in an oncogene addiction. It can be in wild type patients about defining this private signature so that you are sure that the tumor you detect and not a normal tissues. It would be a pity. It's quite expensive, but it will be developed. And it can also be, very importantly, after radio chemo. Remember the Pacific data and all of these data. We perfectly know that some patients need to have 1 year or even more of IO, but some don't. So how can you know who they are? They have a scar after radiation and so on. So I think it will be useful for all of these patients. And like you said, at the end, it's going to be sparing money. It's going to be about giving less treatment.
True that. As we spoke about, about the money, and any discussion about LMICs cannot revolve without having money. We had a huge conversation in our medical oncology fraternity about the fixed dose regimens versus the weight dose based regimens. There has never been a head-to-head clinical trial. There have been always the pharmacokinetic studies which have compared 200 mg of pembrolizumab versus 2 milligram per kg body weight, or a nivolumab 240 mg flat dose. So what's your take on the flat dose versus the milligram per kg body weight dosaging for the patients across?
Well, I remember that there was some analysis about looking at the median patients, right, in terms of weight, size, and so on. If you look at that, by having flat dose, the pharma industry will sell more Pembro and more Nivo, because the usual patient is 70 kilograms, which is not the case in India, which is not the case in China, and so on and so forth. So basically, they have been increasing the dose with the flat dosing, and in most patients, they increase the dose. I think for these antibodies, a small variation doesn't change anything. So I am safe with this flat dose. And the argument of the pharma industry was to say it makes life of all pharmacists easier because it's just a vial, you put the vial and so on. But we have to keep in mind that for the pharma, it's full benefits. They sell more drugs. And for the patients, it's no impact. So what you have to do in low middle income country is to make sure that flat or not, I don't care. You need to have better prices for this drug. And maybe here's a new anti-PD-1, anti-PD-1 will help. So second thing, remember, it's about this compulsory licensing, right? I remember when I was doing HIV, I did fight for HIV drugs in India and China and some other countries, the South Africans and so on, and Eastern Africa. And we managed to have this local production of the drugs with compulsory licensing because this drug was saving lives. So we have to question if this drug like Pembro doesn't save life. I believe they do. So we need to start to do politics in order to make sure that you get some accessibility to low-cost anti-PD-1. And it can be tislelizumab, I don't care, but one of these compounds which are produced closer to you.
We are coming with a paper about the statement regarding dose versus the fixed weight. And I think that's a very important point because in India, the median weight is not 80. It's somewhere around 55, 60 for everyone. So it's a huge loss of resources actually.
And by the way, if you have to argue about one trial which would be important is the interval, right? Because you know this paper from Julie Brammer in 2015, I guess, where she was showing that after 3 or 4 doses of Nivo, you have a plateau for 200 days. So why do you give the next dose after 15 days? So, I mean, this kind of things sound absurd. So we need one day to find the answer.
Again, one more important question which I wanted to ask you, and you showed the data about 2 years. Are there certain specific patients, go back to breast cancer. We are thinking about 1 year versus 6 months. Even in colon cancer, you have 3 months versus 6 months of treatment. Do you think the magical number of 2 years in the first line NSCLC is a magical number, or is there some science to it?
No, I think it's an artificial number. I think it's a marketing number, kind of sharing the capability of being registered because it's not too long, and the potential kind of control which is beyond the median with chemo. So it's purely marketing. But what I observe in these patients with IO at 2 years is that when you stop, they don't do well. So we probably would have had better to do 3 months every 2 weeks or every 3 weeks, and then maybe 5 years every 3 months. You know what I mean? So a completely other schedule might be the future. But it will take us 15 years, right? But maybe it's 5 years, and maybe it's every 3 months only.
It doesn't make a difference, Professor Peters. Even if it's 50 years, our generations will be benefited. It doesn't make a difference. You have to live a legacy.
Yeah.
Okay. A very oft repeated question, Professor Peters, is that where will you use a checkmate 9LA or a checkmate 227?
Okay. So we don't really have prospective data. So this is subjective, right? It's good. We have too many options. For me, thinking also about melanoma, there are really 2 opportunities where I would use a CTLA-4. And these opportunities are the brain mets, because you have, of course, IO works at the brain level, like at the systemic level, but this CTLA-4 adds something incremental. The brain effect is better. And it has been shown in melanoma very strongly. So in brain mets, I would try to use a CTLA-4. And in negative PD-L1, I think that here some longer term benefit might be seen. So this would be my 2 cases. When do I use 227 versus 9LA? Well, in these patients where you feel like they might progress fast, you know, the one with a lot of brain mets and so on, I would potentially put 2 cycles of chemo to make sure that the CTLA-4 has the time to deliver all its effect and not start with the progression, right? So it's more about the very subjective clinical situation of the patient.
Okay. I think, Professor Peters, I have at least 15 more questions, but I'll ask you only one question. And it's a pleasure talking to you, although. Professor Peters, in 2025, you would be giving a lecture on future of immunotherapy. What would be your topic? What would be the next thing in immunotherapy that you will talk about?
It looks completely crazy, but I will speak about T-cell therapy, right? Engineering T-cell. It can be T's, tumor infiltrating lymphocytes, which are engineered to target the tumor, or CAR T-cells. But I'm quite sure that moving with RNA vaccines, for example, if you have an RNA vaccine, you can produce a CAR T-cell by definition. So moving with these RNA vaccines and the T-cell knowledge, I think in some years from now, the future will be some T-cell engineering for patients. And you know, it looks crazy in terms of price and machinery and automatism behind, but it's just about the learning process. So at some point, machines will do it, right?
Professor Peters, it has been an absolute pleasure. And more than the science, I must compliment you for the enthusiasm that you exhibit. I could see the glee in your eye. I could see the smile which you made me answer. Thank you, ma'am. It was a pleasure hosting. Thank you.
A pleasure. Thanks for welcoming me. Bye-bye.
Bye.
Thank you, Solange Peters, ma'am, and Dr. Ullas Batra, sir. I request Dr. Jyoti to say a few words.
So it was an excellent session, Dr. Solange Peters. It was always a great pleasure to have you with us. And thank you for being supporting Immuno-Oncology Society of India successively. You are there for last meetings as well as this time. So we had a very great time listening to you, and also Dr. Ullas Batra for this great discussions. The chairpersons, Dr. Agrawal, thank you very much. This was indeed a wonderful session together. Now over to you, Rekha, for the next session.
Jyoti, can I add my thanks to Dr. Peters also? Thank you very much, Dr. Peters. Really, truly appreciate your presence. Thank you.
Thank you very much.
Yeah. So our next chairpersons are Dr. Amit Dutt, sir. He is Principal Investigator, Scientist F from Actrec Tata Memorial Center, Mumbai. And Dr. Anil Dicruz, sir, is Director of Oncology, Apollo Hospital, Navi Mumbai. Over to you, sir. I request Dr. Amit Dutt, sir, to provide the session introduction.
So, welcome everyone to this session of AI and Big Data. Systematic efforts have led to neutralize the life-threatening elements of several known terminal diseases to mankind. Cancer, however, poses a different problem to nearly all those deadly diseases. These are vast amounts of research-generated data becoming available regarding the different types of cancers, the typical symptoms those are associated with each type, and the available treatments and medicines to keep patients healthy for longer. These developments, parallel with those in fundamental science and biomedical research, have made the field data-driven and AI-enabled. If you think about it, AI and big data in oncology are like two sides of the same coin. Both elements are codependent, meaning that one of them cannot flourish without the other. The combination of big data and AI offers a massive boost for the healthcare in general, and especially in our fight against the cancer. The argument goes on that if AI can teach a car to drive on its own or a social media platform to recognize faces, machine learning should be able to radically improve the diagnosis and treatment of cancer that can help provide accurate prognosis and personalized treatment plans for the patients. With a probabilistic modeling when developing the AI methods. The granularity of oncological data in continuum of scale, quality, and completeness of the available data set is particularly relevant in the context of development of AI systems. These in turn are largely characterized by data-intensive computational modeling approaches to assist clinical decision-making. So in today's session, we would see one such AI-enabled potential and how it's leading to more accurate and rapid diagnosis, improved clinical decision-making, and ultimately better health outcomes for patients with cancer and those at risk. So with that brief introduction, may I request Dr. Anil Dicruz to introduce the speaker. Thank you.
Thank you, Amit, and thank you for the organizers for the opportunity, the pleasure to introduce our next keynote speaker, Dr. Linda Chin. Linda, I want to start out with an apology. And an apology is that the organizers have just given me 2 minutes to introduce you. And when I see your CV, I don't know whether I'll do justice in the 2 minutes that has been allotted to me. But very briefly, Linda is a dermatologist by training. She's a renowned cancer genomic scientist and a leader in application of technologies, analytics, and data in medicine. She's worked at some of the major institutions, the Dana-Farber Cancer Institute, the Harvard Medical School, served on the executive subcommittee of the Cancer Genome Atlas, and co-led development of the Firehouse pipeline at the Broad Institute. She was the founding chair of the Department of Genomic Medicine at the MD Anderson, and later the chief innovative officer at the University of Texas System. Dr. Chen has developed technology-enabled platforms to facilitate the translation of genomic science and analytic insights into the practice of medicine. As the science director at the Belfer Applied Cancer Institute of Dana-Farber, and later at the Institute of Applied Cancer Science at the MD Anderson Center, Dr. Chen developed novel organizational construct to bridge across academia and industry to accelerate science-based drug discovery. Foreseeing the paradigm shift in research and care driven by data and technologies, Dr. Chen founded a digital medicine company that brings together technologies and real-world data with science and clinical expertise to transform cancer care and therapeutic development. Over to you, Dr. Chin, and we look forward to a wonderful keynote on AI and cancer.
Thank you for the generous introductions, and thank you to the organizer for inviting me to participate at your annual Congress. I'm going to step back, and it's a tough act to follow, Dr. Peters. She really has given an enormous overview and capturing all the excitements going on in immuno-oncology for lung cancer. What I want to talk about is maybe step back a little bit. I think there is much excitement and hope for what AI and data will do to transform cancer care and research and drug discovery and development. I want to step back and sort of look at the big picture a little bit and preface this by saying is a lot of what I talk about, and I hope I will comment on it, has to do with the experience that I have had in the last 20 years. Studying genomics, deploying it, generating data, and using the data in discovery of target, validation, downstream drug discovery, and all the challenges that we face. And one thing that I will focus on is, as much as we are now, 20 years later, since beginning of the genomic revolutions in medicine, is the appreciation of the importance of clinical data. Without the clinical phenotype data, genomic data is limited in terms of how it can be used to discover the insights to guide medicine. So let's start and looking at what's happening. Clearly, medicine have witnessed unparalleled advances in this past decades, driven by big data and AI and technology, as we have heard. And the transformation has been supercharged in the last 18 months or 2 years by the COVID pandemic, really ushering in this new era of truly digital medicine. Now, as you see in this summary diagram from IQVIA Institute, digital health tools are being developed and deployed throughout the entire patient journey, empowering both the patients and the healthcare providers, not just in the hospital, but outside of traditional healthcare facility, as shown here. Telemedicine, remote monitoring, to mobile wearable devices. And in fact, we know that, there are now over 350,000 digital apps. There are for health and health-related applications, and they generate enormous amount of data. And this is not just data that we traditionally capture, like vital signs, and laboratory results or pathology result in the electronic medical records. It includes a behavior from how we sleep, how much we exercise, what we eat, and our behavior, such as smoking, and it's tracking these and the environmental factor, including social determinants. and they're giving us a picture about the patient that's never been before. And we all appreciate this as physicians because we fundamentally know that a disease like cancer is not a diagnosis about one organ system. It is, we want to treat our patient as a person, not as, you know, that particular organ system. So how do we imagine these capability and data will transform the way we deliver care, but also how we conduct research and accelerate discovery and development? So I want to talk about this concept and share with you, and I will use some of the strategy that we have developed at this company, Precision Health, that I am part of the founding team on, to talk about how we leverage this as a lesson share. And I hope that most of the comments I make is generally applicable outside of what we're specifically doing in a Precision or in immuno-oncology. So speaking of immuno-oncology, there's no introduction necessary in this meeting. Clearly, it's a transformative breakthrough therapy, and it's been tremendous exciting. But as we heard, chance of the cure comes with toxicity. Not every patient responds, maybe across the board, 15 to 20%, but many, at least half to even 90%, depends on the treatment they're on, will experience toxicity. And this creates tremendous challenge in democratizing immuno-oncology into real-world populations, because toxicity requires experience. A clinical team needs to have that expertise to detect it early and timely intervene and treat these toxicity to maximize the time the patient can stay on therapies and the benefit. And conversely, not surprising, you would have seen this. And this happened to be one of the recent publications from the VA system, showing that the outcome in the population outside the trial is less than what's predicted if you were expecting it based on the pivotal trial data. This post-market efficacy decay is not uncommon, it's recognized, and it certainly is more notable with novel therapy, such as complex therapy like immuno-oncology and combination with chemotherapy. And there are multiple factors driving this gap in outcome, and some of them related to the clinical team, some of them related to patients. Clearly, patients are much more heterogeneous in the real-world population than in a clinical trial. And not only are they less homogeneous, they're also likely to have poor performance status, and there will be social determinants of health that are barriers to accessing the right care in the right time. On the clinical side, the teams is less experienced. In general practice, there's less likely that you have a subspecialist that specializes in a particular disease type, and there's capacity constraint. On a clinical trial, there's a dedicated team that can provide much more intensive care to the patients, including the ones on placebo, the so-called trial effect. The patient on placebo do better than standard care. So these parameters drives this gap, and as you can imagine, this structure bias. These factors drives the structure bias in real-world care, and I hope to come back to that discussion. So when we think about how to address these gaps and maximize the effectiveness of immuno-oncology, specifically from the perspective of data analytic, we imagine that first step is we got to improve delivery of care in the general community, particularly in the underserved community. And how can we use technology to augment the clinicians' capacity, as well as AI to bridge the knowledge gap, so that we can deliver more proactive, best practice care to more patients. We also should think about smarter care. I think there is in the discussion in the previous talk about biomarkers. We absolutely need to be able to identify the population in the paper that are more likely to respond to the therapy and less likely to experience toxicity. And the more we can be precise in identify that population, the more effective the drug is going to be and more cost effective, not just from an outcome perspective. And that's going to require a new way of thinking about how we use this technology in the development. And then, of course, how do we develop the next generations of immuno-oncology drugs? I think one thing that we should, that I certainly have strong feelings about is, as great as model systems for us, we need to begin our discovery in human patient-based data, especially when it comes to immuno-oncology, because there is no model system that recapitulate the complexity of the human immune system. So how can we learn from patients that are in receiving care on a day-to-day basis and learn from them and use them to help drive the discovery of next generations? Now, these are challenges in front of us, and also challenge when we think about the population as a whole in terms of equitable access to novel therapy. And that was what drove the foundation and founding of Precision. Coming together with this team, and I don't think I need to introduce Keith Flaherty, Pam Sharma, or Jim Allison to this group. We came together with the idea that with data and technology, we should develop a system that can help democratize access to therapy in clinical trials and drive the next generation of novel therapeutics. And our approach is less about technology. I think of technology and AI analytic as a tool. They all should be a way for us to use a tool to solve a problem. And to understand the problem, we need to understand the field, and that's where expertise come in. And so our approach is to lead with expertise and bring together a advisory board that had the people who really have decades of experience in this area from the very first clinical trial. And with their help, we sort of drove down to identify several key drivers that contribute to the clinician-related contributor of the outcome gaps. Compared to a clinical trial, when you're in the real world practice, it's much more challenging to have the resource to be able to monitor your patient intensely and maybe even proactively. So how can we help a real world practice to be proactive and monitor the patient in between clinic visits? Secondly, experience. It took experience in the clinical team, and not just the oncologist, the entire team, to recognize early signals. And that experience to recognize the early signals key to early diagnosis and detections of toxicity. And then knowledge and familiarity with evidence-based guidelines is important to use best practice to manage. So how do we think about technology to support and augment this area? And then at the end, providers. I think one thing that I like to make the point is being in the field of technology and data analytic is often that people think the computer can solve the problem. And I would say maybe someday in the future will, but not in the foreseeable future. Computer, data, analytics, they do not take care of patients. You still need trained and skilled providers who can use those insight and tools to take care of patients. So without those providers, we can't take care of the patient. So provider shortage is continued to be a problem, particularly in area of novel therapy like immuno-oncology, because even among the practicing oncologists and extenders in this field, they're less experienced with this new therapy. So how do we address that? So without going into a lot of detail, and I don't want to talk about the specific technology, what we have built over the last couple of years is an integrated solution called a PreciRx. This solution is designed to integrate the ability to remotely monitor the patient, whether it is subjective patient reported outcome or device monitoring of vital signs, with telemedicine capability, so that we create that connectivity 24/7 between patients and the healthcare provider team. But importantly, not only do we have to integrate these patient-reported outcome data with the EHR so that we have the context of that clinical history, to interpret that symptom that the patient may be experiencing and reporting, we developed this AI decision support system to support the clinical team to recognize the toxicity and deliver and perform the right evidence-based diagnostic and management. And that's important. And to develop that, it's not just about the oncologist making that treatment decision, but it's just as important to provide the AI support to the extended team, because the first contact with the patient that may be experiencing a symptom is probably the nurse. So if our oncology nurses are not experienced to recognize the significance of particular symptom, the patient would not be escalated to the physician. So a physician that's well experienced is not enough. You need the entire team. So we developed that decision support to for triage from the very beginning in front door all the way to decision in terms of diagnostic workup and therapeutic management of toxicity. Now, as I mentioned, we also appreciate the shortage of trained skilled providers. One problem, I would say problem with a crow, with proactive monitoring of patient is identifications of very mild symptoms. And that is what we want to do. We want to identify these symptoms when it's mild, when it's easy to treat, so that patients don't have to have, will not suffer from long-term consequences. And the same in other disease, not just in cancer. But that also means it creates a lot of low acuity care that the oncologists have to deal with. And they, we don't have enough oncologists around to take care of them. So we have to think about how to expand the team to help address these low acuity events. So what we built on top of this technology platform is a dedicated team. Think of it as the Uber for a skilled oncology extended teams. It's on-demand staffing so that we can provide the coverage when the oncologists cannot, do not need to manage this low acuity event. For example, our focus is after hour. When 5 o'clock, when the office and clinic close, patients still develop the symptom, but the oncology team cannot work 24/7. So who can step in and provide the after-hour coverage from 5 p.m. to 9 a.m. so that the patient are not left to deal with where and how to manage their symptom and who to call and when to call and whether they need to go to the emergency room. Now, we see this as a health equity solution. In fact, we have partnered with Stand Up to Cancer and BMS to release a RFP for this project, the Catalyst project that's currently active. And the way we think of it as an integrated health equity solution is that what we do is that this together, not just the technology and not just the people, but integrated, allow us to go and help a practice in a, for example, underserved community, provide them the capability to proactively and intensively monitor their patients on these type of therapy, bring the experience to help intervene at the right time, and put at the tip of their fingers the best practice recommendations, so that we lower the barrier on the clinical side to prescribe novel therapy that they may be less familiar with, but importantly, we also help make sure that patients are optimally benefiting from these novel therapy. So this is how we think about the integrated technology and data can help us address the gap and narrow the outcome disparity that I showed earlier. Now, as we do this, not surprisingly, you know that we're capturing data, more granular data that is not in the traditional electronic health records. So how do we use that to drive genomic research, and how does that help us in terms of lowering the barrier to clinical trials? Now, this is an old slide, early day, but from that point on, there has been many studies showing that serial profiling of patients' tumor, not just pre-treatment profiling, which is how the Cancer Genome Atlas was started with. The serial profiling is it's important to develop robust predictor of response. And this study by Jen Wago from when she was still in my lab started this study to show that in the immuno-oncology space in melanoma patients. She showed that there are markers that may be changed, but the changes are much more significant and robust when the assessment is performed on patients that are post early treatment, like after the first dose or second dose. And this pattern has been recapitulated in many, many studies since then. And it's not surprising because the human immune system is highly complex. Like any other complex system, the perturbation and then how a system reacts to the perturbation is what it takes to analytically identify marker and signal that tells you how it will behave. And this is what that is. Pre-treatment, you're looking at a complex system, but when you perturb it with the first dose and second dose, now you see how the system reacts. Now you can much better predict whether that will lead to ultimate response. Now, there was a discussion earlier in the previous talk about liquid biopsy, because tumor biopsy is limited. Tumor biopsy is something we can do in clinical research. Even there is a limited subset of the patients. Liquid biopsy is much more easily accessible, and you can now imagine how to extend that research to a broader populations. So this is a unpublished data, and I borrowed this from our colleagues from MGH, where they partner with Olink proteomics to assess the plasma proteomics of metastatic melanoma that are on immunotherapy. And what they've looked at is baseline, 6 weeks on treatment, as well as 6 months. And what they found is consistently, the baseline profile is less predictive. And obviously at 6 weeks, you can see many more proteins differentially significantly expressed, and therefore providing a signature for response versus non-response at 6 weeks. And that's a very important biomarker once validated, because clinical overt response or non-response could be months later. Knowing it at 6 weeks gives you the opportunity to adapt the therapy so that you minimize unnecessary toxicity and certainly the cost of an expensive drug if the patient are not going to be responding. Now with this, what that tells us is that at least in some patient population, you may be able to assess response to therapy without the tumor. Now the question is, can we do this with toxicity? Because remember, we need to deal with both the response and the toxicity, because the current picture of response and then high prevalence of toxicity means that we need to have an understanding of the relative anti-cell and anti-tumor effect of these drugs so that we can identify the population that have low toxicity risk and high response risk. And so the ideal biomarker would give us both sides of that coin and not just one side. So what we need here is we really do need human patient data, because it is challenging, and I would not use the word impossible. I don't know how one will model the toxicity in a cell-based or organoid or animal model system. I think we need to study the actual patient. So how do we now get this longitudinal data about the clinical phenotype of the patients, coupled with molecular research data so we can better understand the basis of toxicity as well as the biomarker that can help us mitigate toxicity to this therapy. Now, I think about genomic as evolutions. Certainly 15 years ago when the cancer genome atlas began, it was transformative. It showed us that pre-treatment baseline profiling tell us something about the tumor, identify the Achilles heels, develop that targeted therapy so that the cancer will respond. I just show you some data, and other have talked about it in this and many other conferences, that now we understand that serial biopsy is necessary to inform how we can better predict response or non-response to this class of therapy. But most serial biopsy is performed in a predetermined way because it's performed at this academic center or hospital when patient comes back for their dosings. That's when, at cycle 1, cycle 2, cycle 3, you can collect the sample and then you correlate that to their clinical outcome. And however, when it comes to toxicity, that clinical a history of toxicity oftentimes is poor quality because it's based on recall of the patients. And the sample you collect could be far away, as I show here, far, days away from when the phenotype of the toxicity happened. So what I consider is a third generation of cancer genomic is what I call phenomics, or phenotype guided genomic study. And as I try to illustrate here, what we want to be able to do is not only having sample to study, but we need to have the ability to collect sample at the time when phenotype began, such as particularly in toxicity. That could be in between clinic visits. And what that means is that we have to have that ability to access patient and have multiple, and therefore we are now generating a cohort of sample that is always linked to a particular clinical phenotype, so that the molecular data we generate, it contextualizes it and is also personalized to the individual patient. And how we can do that is to utilize the system I mentioned to you, right? By having built the remote monitoring to capture and patient-reported outcome data and intervene. It also gives us a data point that tells us the time at which point the patient is experiencing symptom. And then that gives us the opportunity to say, now, can we obtain a sample at that time, close to that phenotype, so that we get high resolution biospecimen and high resolution molecular data that correlates to it. So this is what we developed as the SMART protocol. And we now have opened this protocol at 2 academic centers. And the idea is that imagine you start your patient on therapy and you follow them, like in a movie, prospectively in real time, identifying onset of symptom and intervening. And at the time of intervening, you collect samples. So now you have biopsy sample that's linked to those phenotypes. And what that allows us to do now is, looking back, being able to do the kind of analysis that compare patients that develop symptoms that progress, requiring treatment or termination or discontinuation of IO therapy, versus patients that didn't develop toxicity symptom, or they develop mild symptom and resolve on its own. Because right now the study of toxicity rely on patients that are severe enough to get that they are shown up in the emergency room or perhaps admitted. And that means you're only studying this group of patients. By doing this serial monitoring and collection of sample, we now can compare the cohort, which are important actual control cohort in the population of patients that are able to balance their the drugs anti-self and anti-tumor effects. And more importantly, with the digital health system in the community setting outside of academic center, we are now taking this protocol to the community practice, because what we want to do is being able to follow these patients and get sample when they develop symptom at grade 1 and grade 2, not just when they are severe at grade 3 and grade 4. And we want to do that in a diverse population, patients that generally are not ending up in academic centers. And that will give us a broader view. And importantly, the participations of real-world community-based practice in these genomic research means that we can now have a more diverse and representative research data set. And that is foundational to downstream biomarker discovery, therapeutic target discovery, and development of AI analytics. So to address the bias downstream that we're becoming increasingly aware of, we have to go beyond just improving recruitment to clinical trial. We have to change and mitigate that bias in the foundational data, which means getting this population participates in research. Now, in the final minutes, I want to talk about clinical trial. So if we can deliver the best practice in broad community to benefit patients, if we can have biomarker to be smarter to care.
Thanks a lot.
Okay, all right, so let me accelerate. We also need to lower the barrier to clinical trials so we can accelerate development of new drugs. And I will just mention this one point. Decentralized clinical trial is one way to get to patients that generally do not participate in trial. And technology can help, but we must address one big elephant in the room, which is when we decentralize the trial to less resource and less experienced study sites that's close to the patient, you also increase the risk of suboptimal safety and efficacy monitoring, and therefore suboptimal endpoint. And if we don't address this big elephant in the room, we will not be able to open study site near patient and truly change the access. And that's what we consider one way to really think about providing the support, centralizing decision support, and monitoring the patient so that we assure that not only a patient at a site near at an academic center and a site in the community can get the same level of intensive care, same experienced team, and also improving that adherence. And this way is what we need to truly bring the clinical trial closer to the patient. So I'll end here saying that with technology, I gave you an example which are generally applicable to many others to accelerate improvement of care and trial, as well as research, leveraging digital application and digital health tool. And I hope that some of these lessons can be applied in your field, and that our goal is to create this learning health system that and help patients in not just in academic center, but in the community to equalize quality of care and access to research and clinical trial. I'll end here, and I apologize for running over time.
Thank you, Dr. Linda, for this wonderful talk. I now invite our lead discussant, Dr. Manish Singhal, sir. He's Senior Consultant Medical Oncologist from Indraprastha Apollo Hospital, Delhi. I request Dr. Singhal to take one or two questions due to less timing, and we can answer the other questions in a chat box.
Yeah, thank you. Thank you, Rekha, and thank you, Dr. Linda, for that wonderful talk and insight into how artificial intelligence can be incorporated into healthcare, right? And especially in respect to the immuno-oncology perspective. And of course, right from the very basics of artificial intelligence, such as telemedicine, digital healthcare, to also in predicting outcomes in patients who are going through immuno-oncology treatment, but also to predict efficacy as well as the side effect profile. Is there any questions in the chat box already? I don't see any questions.
Sure. May I?
Yeah, please, Dr. Amit.
Yes. Thank you, Dr. Chen. This was indeed a great remote care service with regards to the precision in managing associated toxicities for the drugs that are actually approved in ideal settings of clinical trials, but may be very different from the real world efficacies. And that too, what you are developing it in the form of a phone app out of a doctor's office, which indeed is a true example of democratization of the diagnosis by the patient. That was absolutely very interesting. So I was just wondering, how do you actually normalize or objectively to say contextualize the data generated with a plural set of expertise to make a meaningful conclusion? Because now the data is being recorded in a very plural settings. So
I think you're asking how do we assure that the assessment in a centralized team is equivalent or the same to the expert in the world. So a very good question, and I think there were two answers to that. One is the reality is that even in the academic center, there's variability and unevenness among the team. And so we try to use AI decision support so that now there are two ways we're doing and ensuring that trained staff, we standardize the symptoms. So for example, if someone's complaining of a symptom of fatigue and because of the experience of team, and you worry, and the patient's on checkpoint therapy, and you're concerned about endocrinopathy, the decision support would guide the team to make sure they consider related symptom so that you capture the information consistently. It doesn't matter who the patient is. And then the decision support guiding the nurse who is doing the triage to ask all the relevant questions, as if you have an expert who has been doing this on a trial for many, many years. So you capture that. So now, from that point on, every patient, you are assessing the comprehensive symptom history, as well as the clinical assessment by the nurse is guided through it, so that you provide a certain consistency that you won't even get within an academic center. But when it comes to truly interpreting the complexity of that patient's profile, I don't think there's anything the AI can replace what an expert can do. But we absolutely can provide a much better, the 80% of the cases, consistent data capture and consistent evaluation in terms of comprehensiveness and uniformity.
Dr. Linda,
this is more setting. Sorry,
I think we are running short of time, Dr. Amit. So we'll just take one question. One last question. You think, Dr. Linda, that our dependence on the AI would increase in the future? And what does the future hold as far as AI and immuno-oncology is concerned?
Yes, I think AI is is not going to go away. AI is part of us, Dr. mentioned, is part of what the future of medicine is, and certainly in immuno-oncology. But one caution that I want all of us to be aware of is that AI is not magical. AI is a tool. AI needs expert who knows how to use it, and it does not replace expert. And I think that's a very important point to keep in mind, because if we suggest that AI can replace our clinicians, I think that defeats the purpose, because AI is there to augment there and allow them to take care of more patients. And I think the press conversation about replacing clinician is the counterproductive conversation. And moreover, the truth is, I think all of you have firsthand experience with a patient. I have not come across a patient when they are truly sick, want to talk to a computer, at least not yet. So until that's the case, I think we should really think about technology and AI to be the tool that empower clinicians rather than them being front and center and replacing our clinicians.
Right. You think AI will ever have human touch?
I'm sorry?
Will ever AI have human touch? The magic of
human touch?
Yeah.
I would never say never. I'm sure the future will come. But in the next 10, 20 years, no. I think AI is powerful in empowering us to do better.
Right. Thank you so much. Over to the organizers.
Sure.
So thank you, Dr. Linda, for this wonderful lecture. And, it is always extremely exciting. You ended in a very, very, positive note that we are still not replaceable. It is assuring. But maybe who knows that in the future IO lectures, you will say that now AI has got the human touch and perhaps we are replaceable. But this was a great talk and very intense discussion. Dr. Manish, thank you for that, although the time was less, but we will keep posting questions in chat boxes. Thank you, chairpersons, for keeping the time bar and, actually taking the session very crisply, Dr. Amit Dutt and Dr. De Cruz. So thank you, everyone, and over to you, Rekha, for next proceedings.
Thank you for having us.
We are moving to a presidential oration session. I would like to invite Dr. Shubhada Chiplunkar ma'am. She is president of Immuno-Oncology Society of India, along with co-chair Dr. Rakesh Jalali sir. He is medical director and head, Department of Radiation Oncology from Apollo Proton Cancer Center. Over to you, ma'am.
Yeah, thank you, organizers. It is indeed a pleasure to chair the presidential oration being delivered by Professor John Hannon on the topic Precision Immuno-Oncology by Targeting Neoantigens. Now, a brief introduction to the topic. Besides checkpoint inhibitors and CAR T cells, an emerging area for novel immunotherapy is occurring through the discovery and characterization of neoantigens in cancer. Gene mutations caused by genetic instability during carcinogenesis always occurs in the non-coding and coding regions, and the amino acid sequence changes caused by non-synonymous mutations in the coding region can produce proteins that are not found in normal cells and can activate the immune system to attack cancer cells. Neoantigens are also produced by viral infections, alternate splicing, and gene rearrangements. These antigens are presented on the cell surface and subsequently recognized by T cells under the action of MHC molecules. They are different from classical tumor-associated antigens like HER2, MUC1, or MAGE, which are not unique to tumor tissue. Neoantigens possess stronger immunogenicity and high affinity towards MHC and are not affected by central immune tolerance. Neoantigens are highly individual specific and usually do not involve known oncogenes. Further, targeting these tumor-specific antigens do not easily induce autoimmunity. These antigens can serve as ideal targets for therapeutic cancer vaccines and T-cell-based therapies. Identification of neoantigens needs optimized algorithms and validated methods for accurate prediction in order to select more reliable neoepitopes of high immunogenicity. Factors to be considered for tumor neoantigen prediction include HLA typing, mutation analysis, prediction peptide processing, TCR binding force, MHC affinity. Neoantigen screening and assessment of T-cell responses can be done in addition to next-gen sequencing, high-resolution tandem mass spectrometry techniques, as well as in silico techniques for peptide prediction can be used. Promising results of neoantigen-based vaccines in preclinical studies have raised significant interest in their clinical applications. The main platforms for neoantigen vaccine are synthetic long peptides, DNA vaccine, RNA vaccines, and dendritic cell vaccines. In addition, adoptive T-cell therapy targeting neoepitopes have shown significant efficacy. As monotherapy, neoantigen vaccine is not sufficient for tumor control, primarily due to the inhibitory tumor immune microenvironment. However, combination therapy with checkpoint inhibitors overcomes this obstacle. The efficacy of immune checkpoint inhibitors directly depends on the activity of neoantigen-specific T cells. There is accumulating evidence to suggest that cancers with high mutation burden are associated with survival benefits from both anti-PD-1 and anti-CTLA-4 therapy. Manipulating the composition and abundance of T cells would be another approach to enhance treatment effect of immune checkpoint inhibitors. Thus, adoptive T-cell therapy and personal vaccines directed at neoantigens are attractive tools for cancer immunotherapy. With these words, I look forward to the talk today and I invite my co-chair, Dr. Rakesh Dalali, to introduce the speaker. Thank you.
Thank you, Dr. Chiplun. It's with distinct pleasure and honor to introduce to you the presidential orator of this year's IOSI, Dr. John Hannan. Dr. Hannan is currently the head of the Division of Medical Oncology and staff scientist in the Division of Immunology and professor of translational immunotherapy of cancer at the Leiden University Medical Center, Netherlands. Dr. Hannan, after finishing his MD at Leiden University in 1988, went on to devote his time in immunohematology and blood bank, initially at the Leiden University Medical Center and then at DNAX Research Institute in California, and defended his PhD thesis on human CD4 helper T cells reactive against mycobacteria. He went on to focus further training in internal medicine, initially in the Leiden and The Hague, and eventually registered as a consultant internist. From 97 to 99, he did a postdoctoral fellowship in the Division of Immunology of the Netherlands Cancer Institute, NKI, Amsterdam. And from 99 to 2001, he trained himself as a medical oncology and was appointed as a faculty position as a consultant and the research group leader at the NKI. His research has been focused on the development of innovative immunotherapies in collaboration with Professor Ton Schumacher. In 2008, he was appointed professor of translational immunotherapy of cancer at Leiden University Medical Center, and from 2009 to 2018, he headed the Division of Medical Oncology at NKI, and from 2018 onward was appointed as the Chief Scientific Officer Immunotherapy, which was one of the, and currently still is one of the major research themes at the NKI Amsterdam. Dr. Hannan's current research
includes development of cellular therapies for solid tumors, neoadjuvant immunotherapies, and very pertinently, as we have heard from last 2 days as well, on biomarker research and adverse events in immunotherapy. His clinical specialty is melanoma and skin cancers and kidney cancer, and as I mentioned, the management of immune-related adverse events. Not surprisingly, he has co-authored over 300 peer-reviewed articles, served as the editorial board of ESMO Open, cancer treatment reviews and kidney cancer, and very importantly is currently the editor-in-chief of ESMO IoTech. Dr. John Hannan was the scientific co-chair of ESMO IO Congress from 2016 and 19, and of course was the scientific chair of the ESMO 2020 Congress. With these words, on behalf of each and every member of the Immuno-Oncology Society of India, it's our great pleasure to introduce you to deliver the presidential oration of the third annual conference of the Immuno-Oncology Society of India 2021, Dr. John Hannan. Dr. Hannan, please.
Okay, thank you very much for this very kind introduction to speak here today on the annual Congress with this motto, choosing wisely when talking about precision immuno-oncology. So I also took the title of my talk into precision immuno-oncology by targeting neoantigens. And here are my disclosures. When we look at the current biomarkers for immuno-oncology, it's clear that compared to targeted agents, targeted therapies, we are still doing quite poorly. Approved are PD-L1 expression, based on which in some tumor types we are allowed to give anti-PD-1 or anti-PD-1 treatment. MSI high is another marker that can easily be used to identify patients with high tumor mutational burden, and also these patients are now being treated with anti-PD-1 or the combination of anti-PD-1 and CTLA-4 treatment. But other biomarkers such as T-cell infiltrate, interferon gamma signatures, and other signatures are still far from use in daily practice. This is quite different from the targeted therapies where we have BRAF V600 mutations, GFR mutations, L translocations, HER2 expression that really allow us to select carefully patients that may benefit from the targeted agents. And one of the reasons for that is that these targeted therapies are based on the binary presence of a certain biomarker. When the biomarker is absent, you are very unlikely to benefit from the therapy. When the biomarker is present, you are likely to benefit. And of course, it doesn't say anything about duration of the benefit.
Okay.
However, when we look at immunotherapy,
yeah, I'm busy with my webinar. So
we can
I'm
have
busy.
very
Bye.
low expression, which still gives you some chance of responding. But we know that when you look at very high expression, you have a higher chance of responding. But it's clearly a continuing biomarker compared to the binary biomarkers that we have. So that is something that we have to deal with. When we look carefully at for instance, this graph coming from the presentation presented by Dr. Cesar at ESMO 2020 on the Empower Lung 1 trial, where investigators looked at the expression of PD-L1 in patients that were either treated with immunotherapy or with chemotherapy. You can see the high expression of PD-L1, over 90%, has a much higher objective response rate than patients with lower than 50% or a non-expression, which goes back to about 26%. And it's nicely depicted here in these graphs showing the size of the response occurring in patients with either a very high expression of PD-L1 or a very low expression of PD-L1. So a couple of years ago, we realized that in order to understand whether immunotherapy could work in cancer patients, we needed to describe the interaction between the cancer and the immune system. For that, we developed the cancer immunogram. This work was done especially by Christian Blank and Ton Schumacher at NKI. We know that tumors that are foreign to the immune system have a higher chance of being recognized and therefore could be cleared from the system. But we also know that other parameters, like for instance the general immune status of a patient, for instance by just measuring the absolute lymphocyte count, the infiltration of immune cells in the tumor environment, either the absence or presence of checkpoints on immune cells or tumor cells, but also, for instance, whether the tumor is sensitive to immune effector mechanisms. For instance, is there MHC expression, or can the tumor respond to interferon gamma? And there are many other mechanisms, for instance, like metabolic pathways or pro-inflammatory environments that can impact on the chance whether a patient will respond to immunotherapy. Over the years, this immunogram has evolved and has now become even more complex with many more possibilities to target. So you can imagine that we're still far from using combinations of these different biomarkers in clinical practice. And probably, as something that you heard also in the previous presentation by Dr. Linda Chin, is that you need combinations based on large data sets, and we probably need artificial intelligence, machine learning algorithms to help us sort out what are the best biomarkers for an individual cancer type and also for an individual patient, depending on a combination of some of these biomarkers. So this is quite complex, and it is not something that we wanted to continue with, and therefore we took a little bit a different approach. We just focused on one particular part, which is the T cell. The T cell is the ultimate effector cell in the immunotherapy that we give to our patients. So we realized that by looking carefully at the T cells, we may get some more information about how these T cells could work. And of course, every T cell is defined, at least for its specificity, by the presence of a certain T cell receptor, which can bind to an MHC peptide complex. These peptides can be derived from endogenous proteins or from foreign proteins, for instance, viral proteins. And every T cell has a receptor that is specific for especially proteins or protein fragments that are coming from outside, so they are foreign to the immune system. Still, we do know that some of these T cell receptors may be able to recognize shared antigens because tolerance to these antigens was not complete. Some of these antigens are shared between patients. We can think about, for instance, lineage antigens, overexpressed antigens. But we also realize that many tumors have many mutations, and that epitopes could arise as a consequence of these mutations. Those antigens have been largely ignored over the years because they were very difficult to address. So we asked the questions, what are neoantigens? Neoantigens can develop because malignant transformation alters the repertoire of peptides presented by MHC molecules. In several ways, oncogenic pathway activation and epigenetic changes allow expression of genes that are normally not expressed in healthy tissues. Examples of that are cancer-testis genes. These are normally expressed during embryogenesis, but then are epigenetically silenced, and if they're not expressed during time of development of T cells, these antigens may be truly foreign for the immune system. An example of that could be, for instance, the NY-ESO1 antigen, which is a cancer-testis product. Also, in virus-associated cancers, expression of any open reading frame coming from viral the genome can be considered a potential source of neoantigen. A very likely explanation or example, is the HPV-associated cancers. HPV type 16, E6, and E7 proteins are required for oncogenic transformation. These proteins are expressed and can be recognized by the immune system as foreign antigens and therefore could serve as neoantigens. But when we talk about neoantigens, most of us think about the accumulation of genomic alterations that can lead to completely new stretches of amino acids, of which some can bind MHC. These are not expressed in normal cells, and therefore no central tolerance exists. The way they develop are single nucleotide variants by site-specific mutations, insertions and deletions, leading to frame shifts and therefore new possibilities of proteins or protein stretches and structural variants. Neoantigens are not new. It's not that we don't know that they existed. We already know that they existed in the 80s and 90s of the past century, when they were first described, but very anecdotally. As of around 2010, when next generation sequencing became available, we were able to really identify the mutations in cancers and thereby also detect potential neoantigens. So how do we detect neoantigens, and how do we know whether these neoantigens are truly important and can be recognized by T cells? For this, we have a workflow that allows us to detect and predict and validate these neoantigens. We start off with tumor cells, so from a biopsy from a patient and also a blood sample from the patient. We perform DNA sequencing and variant calling by comparing tumor DNA and normal DNA, and we find those mutations that are specific for the tumor. But not all mutations are in genes that are expressed, and of course we need proteins in order to generate epitopes that can bind to MHC. So we have to look also at the tumor RNA, and then based on that information, we have in silico neoantigen prediction algorithms like NetMHC and NetChop that allows us to predict for any MHC molecule of the patients whether around stretches of mutated amino acids there are epitopes that could bind to the MHC molecules. That, of course, doesn't tell you whether there are T cells that could recognize these. So you need to have also an assay that allows you to detect whether or which of these epitopes that are presented by the MHC molecules or could be presented by the MHC molecules are truly detected by T cells. And then we talk about validated neoantigens. Another approach for antigen or neoantigen discovery is based on MS-based immunopeptidomics. So in this situation, a tumor fragment is being amino affinity purified, where you get HLA complexes. Then the peptides within the HLA complexes are eluted and are recovered, and then they undergo high-pressure liquid chromatography and mass spectrometry analysis. This then gives you, as a result, a number of epitopes with the amino acid sequences that you can look for whether they exist and are produced in large databases of proteins. Then you can synthetically generate these peptides and generate MHC multimers consisting of MHC molecules with these peptides to screen TIL or peripheral blood T cells for the presence of neoantigen-specific T cells. So when we compare the pros and cons of methods for neoantigen detection by comparing, for instance, the in silico methods that I just mentioned, or the mass spec methods, or the T cell assays, you can see that there's quite a difference here. The in silico predictions are usually a high throughput method, but unfortunately, you end up with many false positives because you may come up with more epitopes than are truly produced by the tumor, and there's no direct confirmation that these are being produced. Using the mass spectrometry method, it's a low throughput method, you end up with false negatives. You may not be able, because of the sensitivity of the assay, to find all peptides that are being presented at the cell surface, and T cells may only require a couple of MHC peptide complexes in order to recognize a tumor as foreign. But here, there's a direct detection of MHC presented neoantigens. And also the T cell assays are low throughput, may give you false negatives because of the lower sensitivity. And again, you are allowed to detect the T cell recognized neoantigens. So how do we know that neoantigens really matter? Also, 3 layers of evidence that I want to go through. First of all, occurrence of T-cell reactivity against neoantigens, and I'll show you an example of that. Then, of course, there may be a relation between the tumor mutation burden, neoantigen burden, and clinical outcome to immune checkpoint blockade. And anti-tumor effects of therapeutic manipulations of neoantigen-specific T-cell reactivity, for instance, by using either neoantigen vaccines or adoptive cell therapy with neoantigen-specific T-cells, is a way of knowing that these neoantigens truly matter. So let's start with the first. A couple of years ago at NKI, I performed a clinical trial with what we call tumor-infiltrating lymphocytes. So this TIL treatment, for TIL treatment, a tumor resection of a metastatic lesion is required, where we isolate the tumor cells and the tumor-infiltrating lymphocytes. Then we perform the identification of tumor-specific mutations, like I mentioned, by performing DNA sequencing, RNA sequencing, and using the in silico prediction algorithms to predict the potential epitopes that could be produced by these tumors. We generate, using synthetic peptides, MHC multimers with these epitopes and screen the tumor-infiltrating lymphocytes from this patient for the presence of neoantigen-specific T cells. This patient had a complete remission lasting now so close to 10 years. So here you can still see the scar of the metastatic lesion that was resected in his right upper leg. And these were the in-transit metastases of this patient. And he had failed BRAF inhibition, ipilimumab, which was at that time available, and chemotherapy. As you can see here, a couple of weeks later, he had a complete remission, which is still ongoing. And here you see the decrease in tumor burden, which rapidly occurred. In the TIL infusion product, we found 5 different neoantigen-specific T-cell populations. Some very small, smaller than 0.1%, but one very large. So 29% of all the TIL that were present in the infusion product was specific for this RBM12S2L mutation. Then we asked the question, what happened after TIL infusion and whether these cells were already present prior to infusion? And as you can see, when looking in the peripheral blood at several time points following TIL therapy, you can see that already prior to infusion, at a very low frequency, these T cells specific for this RBM mutation was already present. Following infusion, you can see that there was first an expansion of the cells in vivo, followed by a contraction of the cells, and at almost 3 years, about 2% of the cells are still in circulation, specific for this new antigen. And of course, we want to believe that these cells have been instrumental in clearing the melanoma metastasis of this patient. Another approach is by looking at MSI high. Of course, we know that when you have a mismatch repair deficiency, then of course a lot of DNA damage is occurring in these in these tumors. And you can modulate that or let's say mimic that in a for instance a melanoma cell line, where in which you using CRISPR-Cas system knockout, for instance, one of these the mismatch repair enzymes, MSH2. So when you do that and start passaging these cells, over time they start accumulating mutations because they have a problem in repairing the mutations that occur during divisions. And at 12 weeks, so after serial passaging, these tumors have a high tumor mutation burden, as you can see here in the genomic MSI score. Now, when you inject these tumors into mice and then treat these animals with an anti-PD-1 drug, you can see that following infusion of these tumors and look at the T cell infiltration, when these animals are treated with an anti-PD-1 drug, you can see there's a high increase of CD3 positive cells in the tumor microenvironment, and these tumors are cleared. It matters even whether you have within the proportion of tumors that have already an MSI high score, whether you have more mutations or fewer mutations. The more mutations you have, the higher the chance that you respond to immune checkpoint blockade. So even within a situation where there is already a high tumor mutation burden, even a higher tumor mutation burden is still beneficial for the immune system, and therefore you have the best results following immune checkpoint blockade. And this is also translated into a better progression-free and overall survival. We know that there's a relationship between TMB and neoantigen burden and response in colon cancer, and especially in the MSI high tumors, but also in melanoma and in non-small cell lung cancer. We know that this is the case. And in non-small cell lung cancer, TMB has now been a biomarker that's being used also clinically. And of course, all this points to the direction that these neoantigens truly matter for immunotherapy. So the last approach is, could we use now these neoantigens in precision oncology? And of course, that's quite complicated, because in order to do that, we need to know the mutational makeup of the tumor. So we can do that by taking either a surgical biopsy or a biopsy from a tumor and define which of these neoantigens are being expressed. And we can use the systems that already mentioned. Use the bioinformatic pipeline to predict the antigens, and then either use that information to generate neoantigen cancer vaccines, or continue and try to identify the T cell receptors that are specific for these neoantigens, clone these receptors, and then by putting them into normal cells, create a large army of neoantigen specific T cells for adoptive cell therapy. Now, these trials with using these technologies are already ongoing, already had been performed. So we show you two examples. One study performed with a neoantigen synthetic long peptide vaccine in combination with anti-PD-1. This study was published last year in Cell by Patrick Ott from the Dana-Farber. In this study, melanoma, non-small cell lung cancer, and bladder cancer patients were included. As you know, these tumors have a high likelihood of responding to anti-PD-1. So a tumor sample was obtained by a biopsy, it was processed, DNA and RNA sequencing was performed, and using the bioinformatic pipeline, the peptides that could bind to the HLA molecules of the patient were generated, and a personalized cancer vaccine was manufactured, and that could, of course, then be given to the patient. This whole process takes about 12 weeks. In the meanwhile, these patients were treated with nivolumab. Then following the generation or manufacturing of the vaccine was then added to the treatment. And then again, the response was observed in this patient population. When we look at the patient disposition of this trial, 82 patients started nivolumab, 60 started the vaccination, and 51 patients completed all vaccinations. 26 melanoma patients, 14 non-small cell lung cancer patients, and 11 bladder cancer patients. So when we look at the outcome, here are the waterfall plots and the spider plots of the patients that were treated either in the melanoma cohort, non-small cell lung cancer, or bladder cancer cohort. What you can see here is that there are two bars within one bar. So there's a dark portion and a lighter portion. So the dark portion are the responses observed with nivolumab alone. The lighter portions, you can see that there are more deeper responses occurring, are a result of the addition of the vaccine. can see the response rate here of this trial, 59% in melanoma, 40% in non-small cell lung cancer, and 27% in bladder cancer patients, and also the durability of these responses that occurred. Translational assays were performed in these patients, which indicated that T cells in the blood from these patients and also at the tumor sites could be detected that were specific for the neoantigens that were within the vaccine. The problem of a trial like this, where you start with nivolumab and then add a vaccine later on, is it's very difficult to prove that what you see is truly the result of the vaccine, or is just a better response occurring over time with nivolumab alone. And of course, we all want to believe that the neoantigen vaccine was really helpful here, because the responses were much deeper than we would normally expect for nivolumab alone. Another approach is making use of a messenger RNA vaccine. And of course, we know that messenger RNA vaccines can be quite potent, especially in the COVID-19 period. Many of us had been vaccinated with a mRNA vaccine. They're highly efficacious in developing a good immune response and also protecting individuals from a severe COVID-19 disease. But these messenger RNA vaccines were in fact first developed for cancer treatment. And here you can see an open how these vaccines look like. There is an open reading frame encoding for the neoantigen, and they are complexed in a nanoparticle, so they generate lipoplexes that are then used for infusion into patients. And the vaccine design is like this. Again, first of all, you need to go through the pipeline of knowing which mutations are in the tumor. You predict the neoepitopes, you prioritize which neoepitopes you would want to put in the vaccine, you generate the DNA template, and then the vaccine is being manufactured. Also, this takes about 12 weeks. Here, again, melanoma patients that were treated first with a tumor-associated RNA vaccination, so with shared antigens, and then once the neoepitope RNA vaccines were ready, these were given to the patient. And some of these patients had simultaneously or afterwards anti-PD-1 treatment. So in total, 13 patients were treated in this trial, all melanoma. Many had stage 3 disease, some had stage 4 disease, some had resected stage 4 disease. And in total, as you can look here, the SNV selected for confirmation were about 40 of these neoepitopes. So this is the time of the patients, these are the patients here depicted, the time prior to neoepitope RNA vaccination, and here is the time following neoepitope RNA vaccinations. The triangles are the resected metastases, and some of these metastases are not resected, are here in gray. And some patients required further treatment, as indicated by these symbols here. But important to tell is, when you look at the increase in tumor burden prior to RNA vaccination, you can see that the curves goes up quite rapidly. But after the addition of the RNA vaccine encoding the neoepitopes, you can see that the curve flattens, and that also translates into a very interesting progression-free survival. Again, it's very difficult to say how important the RNA vaccine was, because these patients might also have been treated with other drugs. But it's very interesting that also in translational research, T cell responses were seen against the vaccine, and also these T cells could be found back into tumor sites of these patients. So again, we think that these vaccines have been important for the disease control that was found in these patients. So the last is the adoptive cell therapy with neoantigen-specific T cells. And again, there are different options that are currently being tried in patients. So Achilles Therapeutics, a company in the UK, uses a selection enrichment of neoantigen-specific T cells from TIL. Another approach is the induction or expansion of neoantigen-specific T cells from peripheral blood, something that is being currently developed by BioNTech in collaboration with NKI in Amsterdam, and by gene editing of peripheral blood T cells with neoantigen-specific TCRs, something that is being developed by for instance, companies like Neogene Therapeutics, Pact Pharma, but also academic institutions. So here's the enrichment of clonal neoantigen-specific TILs. So that's being used by Achilles Therapeutics. Again, for TIL, as I mentioned, a metastatic lesion is being removed, and then this tumor is being, again, genomically analyzed to identify what we call clonal neoantigens. These are shared between all metastatic sites. And once they know the clonal antigens, dendritic cells are being harvested from the blood. They're loaded with these clonal neoantigens, and then the TIL are being expanded that are specific for these clonal neoantigens. And a T-cell product is being generated and being given back to the patient. And we have to see how these trials really go and whether these responses are seen in these patients. Currently, trials in melanoma and non-small cell lung cancer are ongoing. So this is another approach taken by BioNTech, where again a tumor sample is being taken, the neoantigen are being defined, and also the synthetic long peptides are being generated. Then using an apheresis product from the patient, the combination of these peptides and these apheresis product is being used to generate, induce, or expand T cells using several rounds of stimulation. And then you can look at several layers, what the subset is of T cells that are in this infusion product. You can look at the specificity, and you can look also at the functionality, either by looking at cytokines that are being produced or cytolytic function. Just to show you a couple of examples, here are patients that were not treated, but the material was used to identify these neoantigens. You can see that you can induce CD8 T cells and CD4 T cells against neoantigens in these different patients. And we know that both CD4 and CD8 neoantigen-specific T cells can be effective in tumor control. So when we look at the specificity, you can see that either these responses were already present prior to induction, but then are expanded. So these are T cells that are specific neoantigens coming from a memory population, or completely being induced from the naive repertoire because they were not present prior to induction. You can see here that these T cells, following presentation by antigen-loading DCs, are polyfunctional in terms of interferon gamma, TNF, and CD107 expression. And this is also true for the CD4 T cells. And when we look at the cytotoxic efficacy, you can see that CD107 expression is only seen when the T cells see the mutated antigen and not the wild type. You can see again here that they express interferon gamma and CD107 only when they see the mutated peptide, and that they're able to lyse, or let's say to respond to autologous tumor digest in production of interferon gamma and CD107. So these T cells are truly recognizing the tumor and before they're being infused. So the trial setup is like this. It's a dose escalation followed by a dose expansion cohort, and we are currently in the dose level 1, and one patient has been infused, and as of Monday, a second patient will be infused at NKI. And of course, we look at safety and clinical activity. And the last approach is making use of TCRs with defined specificity against personal neoantigens. Again, we need a tumor that will be excised, and from the TIL, we are now able to single sequence thousands of TCRs. And then we can try to identify which of these TCRs are truly neoantigen specific and select, for instance, 5 neoantigen specific TCRs from this pool that we then use to genetically modify T cells using CRISPR-Cas, grow these cells out, and make a personalized ATMP cell product. And these will then be infused to patients. This is still something that has not been done, at least not with multiple TCRs, but that will soon be done at several institutions. So neoantigens can be used as targets for cancer immunotherapy. And currently available immunotherapies, checkpoint inhibitors, work best in cancers with high tumor mutation burden and neoantigen load. Responses to neoantigens may be boosted by specific neoantigen vaccines. I think the current problem still is production time but over time, this will become much shorter. Adoptive cell therapy targeting neoantigens appears a very attractive approach, but results so far are still anecdotal. I think, and there's also something that Professor Peters answered to the question, what will you discussing in 5 years from now? And she said, we'll probably be talking about vaccines and adoptive cell therapy. And I totally agree. This is a very interesting new approach, and hopefully in solid cancers, we will be able to make some progress there. And with that, I would like to thank my collaborators, both at NEON, or nowadays BioNTech US, and the Netherlands Cancer Institute, that were instrumental in order to generate these neoantigen-specific T-cell products. Thank you for your attention, and I'm open to answer any questions.
Can I come in here? Thank you. Prof. Hannon, this was spectacular, almost made us feel that we are living in the dark ages, while you're clearly much ahead of time. The best part is, I'm sure that in some time, maybe half a decade to a decade, we'll all be using this in the clinics. And so your talk becomes extremely relevant because I think we need to understand this better. I've had a number of questions in the chat box. I've got some of my own, and I'll try and divide them into about 3 or 4 groups. But one question that seems to be stemming up is the heterogeneity in tissues. I think there's a concern that when we biopsy or when we take a blood sample and when we look at neoantigen isolation, it is more specific for that day and that time of the tumor journey and the patient journey. And of course, that can vary. So how do you address the tumor heterogeneity and the clone dynamics when we give treatment based on neoantigens to these patients?
Thank you very much for this question. I totally agree that this is still an important issue that we need to tackle. And I think I already mentioned that, for instance, the Achilles therapeutic approach, where they take a tumor and then try to identify the clonal neoantigens. And of course, we are now able to do that. So these are the neoantigens that are shared between the different metastatic sites and are not something that were developed only at a one metastatic site and not present in others, may be the true important antigens that we need to target. And we can take that into account when we generate cancer vaccines. Now, you were right. If you take, for instance, let's say a tumor biopsy, you may miss perhaps these clonal neoantigens. But I still think that the majority of cancer cells will have these clonal neoantigens in them. Otherwise, there wouldn't be the truncal antigens. So even if you would take a biopsy, I think you would be able to recover these and use them for your cancer vaccines. Another important aspect is that one should not try to target only one neoantigen, because these tumors are known to escape, for instance, by getting rid of their antigen. And of course, that would happen if you would target only one single antigen. So it's important to target more than one. So also, when you take a blood sample, even there, it's possible to find these clonal neoantigens, I think, from sequencing data, because the chances are that they are present in the circulation, whereas, let's say, non-clonal antigens, so antigens, neoantigens that are coming from tumors, or let's say metastatic specific mutations, may be at a much lower frequency and therefore cannot so easily be detected. So I think it's still possible to use that approach for the future.
So I think, just let me rephrase that. So you're saying while heterogeneity and evolution is correct, but if you're targeting that by both tissue and blood, as well as using multiple targets, the escape is likely to take time, as was in fact shown by your response rate in the clinical trial, where we saw very sustained responses of the responses that were deep.
So maybe you can repeat that question. I didn't fully understand.
No, I think I was just repeating. I was summarizing what you said.
Okay. Yes, I totally agree. Yeah.
Yes.
Oh, it was a statement, yeah.
Okay, so the other very big question or theme that's coming up is between cold and hot tumor, or in simple words, immunogenic and not so immunogenic tumor. So even the clinical trial that you showed was between melanoma, lung cancer, and bladder cancer, which we already have established are generally considered immune system tumors. In fact, Jyoti in one of the chats talks about TNBC, which we also see can be having a high TILs in some patient. So the question is dichotomous. In patients which have immunogenic tumors, does neoantigen vaccine and adoptive T cell vaccine make this almost imperative because it prolongs the efficacy? And in tumors that are not immunogenic or cold tumors, can we use this technique to make them hot tumors and make them responsive to immune checkpoint inhibitors? And in fact, while you're addressing that, please think about a combination of therapy as well, because that's coming up again and again in the chat box.
Yes, I think that these are important distinctions, right? So I think that for tumors that are already inflamed, this approach, especially in tumors where you have a somewhat higher tumor mutational burden, could be very effective. And we can imagine and envisage that over years, we will be using a combination of these approaches with immune checkpoint inhibitors or other molecules. Even in patients with low tumor mutational burden, finding a couple of neoantigen-specific T cells may already be enough to go forward. But I totally agree that the problem is lying in those tumors that are not inflamed. And the question is, even if you do adoptive cell therapy and use T cells that are specific for neoantigens that are coming from these non-inflamed cold tumors, will these T cells be able to get into these tumors because they are cold for a reason? And it could very well be that we need to treat these patients with some other drugs that allow at least the T cells to get in before we can really get some results.
Bevacizumab, yeah. Bevacizumab is an example of that. Yeah.
For instance, bevacizumab, so an angiogenesis inhibitor, but perhaps also other moieties, could even be, for instance, chemotherapy that can work there as well. Right? Yeah.
Excellent, excellent. That was a very good discussion, actually. I have two more questions, then I'll read out some questions. I think one basic question is, what is the downside of this technology if it really comes? Because from everything I heard from you, it seems like it's a cherry on the top, but well, I could still have the cake without the cherry, couldn't I?
I totally agree. So the biggest problem with this is, first of all, the time to produce, right? Is rather costly to do this for every individual patient. And if these become commercially products, then these will be very costly as well, right? So the price will still certainly be a problem. We know, for instance, that for the CAR T cell field, prices of commercial products are extremely high. And you can imagine this is even more work because it's an individualized product. So this may even be more expensive. Now, I think, therefore, we have to work closely together with academic institutions and start doing this at the academic setting to keep prices low. I think the technologies that we currently have to do this are already present. The only thing that we need to do is to do it a little bit faster so that the waiting time for patients may not be more than 6 weeks. That I think we can bridge. But if you have to wait, let's say, half a year before you have the product, then of course the patient may already passed away before you're able to give the treatment. So I think when we are able to do this in a more high throughput manner, I think we have come quite a long way. And then this treatment option may become very, very feasible to treat many patients.
Okay, I think that's a good point, that it's the time and the cost, which is two things that are stopping us from using this more liberally. That brings us to another question, actually, which I was trying to address. You spoke about the processes and the validation, and I'm sure as the technology gets more liberal. We already know there are parts in China which are trying to do that. How do we really judge? Because we're not educated in this. As clinicians, we're not really reading this and understanding this on a day-to-day basis. How do we judge the processes, the validation, the efficacy? In fact, between mass spec and silico, a simple table you showed there was differences in false negative and false positive. So as a clinician, how do we really judge what's good and what's not?
Yeah, that's again very a good and important question. I think that the best way, of course, to do this would be the combination of the methods that I just showed you, right? So I think when you look at the mass spectrometry immunopeptidomics system, there you at least know that the peptides that are being presented by the MSC molecules of the tumor are there, right? When you use the in silico method, then of course you don't know that for sure. So you could use both in order to find out which of the new antigens are truly presented from the ones that you already predict based on the algorithms. And I think with that combination, we may say that some of these neoantigens can be used for vaccine or for detection of neoantigen-specific T-cell receptors. I'm not sure whether we all need to know exactly how to validate these assays, right? That would be asking too much of many of the medical oncologists. But I think once we have validated the systems, the let's say the workflows to such an extent that we are sure that what we're doing is really generating these neoantigen-specific peptides or TCRs, then I think we can continue. But before that, of course, we need to do a lot of research.
Thank you very much, Prof. Henan. I think we could go on for a couple of hours, actually. There are so many questions and there's so many questions in my mind. But I guess the good things have to come to an end. So thank you very much. Thank you, Jyoti. Thank you, organizers, for having me here. And really thank Prof. It was an honor to be actually speaking to you.
Thank you very much for being here. Absolutely. Wonderful.
So thank you very much, Dr. Hanan, for this outstanding oration. And it is always, very pleasant to listen to you on various forums and interact with you on various ESMO activities and several others. We are extremely delighted to have you, and it is so much humbling to see that the IO field is so much advancing. And I'm sure that when you deliver your next lecture in upcoming IOSI events, we will be much more experienced, and perhaps things will move into clinics, in several folds speed. So with here, because time is limited, as everybody acknowledged, these discussions are extremely exciting, and we can go on and on. But we will continue to be connected with you on mails and chats. And from here, I would again like to thank you from my entire IOSI team, from all the executive committee members, from all the members, and my entire country. Thank you very much.
You're welcome. It was a pleasure. Thank you very much for inviting me. Bye-bye.
Thank you so much, sir. Our next chairpersons are Dr. S.V.S. Dio. He is Head Department of Surgical Oncology from All India Institute of Medical Sciences, New Delhi, and Dr. Heman Malhotra, sir. He is Vice President of IOSI, Director Oncology Services at Shri Ram Center from Jaipur. Over to you, sir. I request Dr. Dio to provide the session introduction.
Good evening, everybody. May I request Dr. Dev to take over? Dr. Dev will introduce provide some initial comments and give the concept, and then I'll introduce Dr. Shonana. Dr. Dev, sir.
Thank you, Dr. Rehmat. Am I audible, sir?
So your audio is very faint. Can you either speak closer to the mic or a little louder?
Hello, good evening. Sir,
We can hear you, sir, but your audio is very faint.
Dr. Dev, little louder or probably maybe closer to the desktop or laptop or your system.
Yes. Am I audible now,
Much
Dr.
better.
Yeah, we are good now, sir. Please go ahead, sir.
My apologies. A very good evening. At the outset, I would like to thank Dr. Atul Sharma and Dr. Jyoti for giving me this opportunity. Now we are going to start the much awaited session, that is immunotherapy for TNBC. So we all know, we are all aware, and we grapple with challenges of managing TNBC. Unlike luminals and HER-enriched tumors, we don't have specific targets for TNBC. So day in and day out, we struggle with multi-agent chemotherapy. But in the last 5 to 10 years, you have seen a lot of good trials coming in the field of immunotherapy for TNBC, starting with keynote trials, impassioned trials. So they have given a new insight to the management of TNBCs, but they have also raised some questions regarding the ideal diagnostics, the ideal companion chemotherapy agents. So now this session, we are going to focus on immunotherapy for TNBCs. I would like to request my co-chair, Dr. Hemant Malhotra, to introduce the speaker. Thank you, sir.
Thank you very much, Dr. Dev, for this background setting. And we know that immuno-oncology has made major strides in most solid tumors, particularly melanomas and lung, urothelial malignancies, hepatocellular carcinoma. But the commonest cancer in women, breast cancer, has somehow been lagging behind in the use of immunotherapy. And possibly now breast cancer is making a catch-up attempt with the rest of the solid tumors. And whether that is true or not, we're going to discuss a little bit of that. We're going to talk about triple-negative breast cancers, and the person going to deliver the talk is my very dear friend, Dr. Shona Nag. And very appropriately enough, she's one of the top breast cancer clinicians in the country. So it's a pleasure and privilege to welcome Dr. Shona and to introduce her to you. She is presently Director of Oncology and Senior Consultant Medical Oncologist at the Sahyadri Group of Hospitals in Pune. And as I said, she's going to focus on triple-negative breast cancers. And finally, immunotherapy is making an impact in TNBC. So Shona, over to you. Thank you.
Thanks, Hemant. That was really a very, very kind introduction, and I hope I can do justice to the talk. Well, after the world of neoantigens, which is really very, very futuristic and glamorous, we are coming back to the clinic with immunotherapy in triple-negative breast cancer, and we're going to see if we finally made an impact. So just to introduce the topic, there have been several molecular classifications that have separated subtypes within TNBC by gene expression profiling. And it's important to understand the heterogeneity of triple-negative breast cancer for prognosis and predictors of response. Unfortunately, these molecular classifications have remained more of research assays, and they've really not been very useful to us for clinical practice. So biomarkers are what really we should focus on, and they're more useful in the clinic for TNBC. We have several biomarkers for the immune-enriched subtype with TILs and PD-L1 measurements. We have biomarkers for DNA repair deficiency, namely the BRCA mutations and HRD scores, and many, many more. There is a strong rationale for immune checkpoint inhibition in triple-negative breast cancers compared to the other types, the luminal and the HER2. Definitely, you have rich infiltration with tumor-infiltrating lymphocytes. You have a much higher PD-L1 expression, and you have a large number of non-synonymous mutations. And there is also a strong rationale for combining chemo with immunotherapy. And if you look at the cancer immunity cycle, we know that chemo itself has several immunogenic effects. We know that IO combinations are synergistic with chemotherapy, and they target different steps within this cycle. So let's look at PD-L1 scoring, and that is one of the methods and assays we use to measure whether immunotherapy is going to be effective for our patients. And there's CPS, there is TPS, there is IC. These are different assays with different cutoffs. The question really arises, are they interchangeable? And this is a very elegant paper by Hope Rugo that was published this year. And you can see they've compared SP142 by Ventana, which is for atezolizumab, and 22C3, which is the DACO platform for pembrolizumab, and you can see that the positivity rate in both was only 36%, and also an overall percentage agreement of 73%. So no, they are not interchangeable. You have to use the right assay for the right drug. That is critically important. Let's look at some metastatic data now, and let's look at monotherapy. We've landed up with very modest responses across all the studies, and the responses range from 5 to 21%. But if you look at the box below in the pembrolizumab story, in the Keynote 86B cohort of 84 patients, these responses, when they were durable, also improved the overall survival. And in this cohort, the survival, median overall survival was 18 months. How do we enrich for responders? How do we get better responses with monotherapy? We use it frontline. We look for high levels of TILs. We look for PD-L1 positivity. And finally, we also look for TMB, or a high tumor mutation burden. This is a very interesting study that was published this year, the Keynote 119 by Dr. Weiner and his group, and he had a very ambitious endpoint, overall survival. This was a phase 3 for second and third line pembro monotherapy versus physician's choice of chemo. Over 1,000 patients were randomized. The primary endpoint was overall survival for CPS more than 10 and more than 1. As you can see in the red box, it did not reach statistical significance. The hazard ratio was 0.78, but there seemed to be a slight separation of curves in CPS for more than or equal to 20. There was an interesting sub-study also published this year where patients with a CPS of more than 20 with visceral metastasis had an overall survival benefit. Another sub-study from this data was in patients with a high TMB, and you can see that pembro instead of chemotherapy also improved the overall survival. What about combinations? As I've said, there's a strong rationale and a strong synergy. So this is just data that you all know, but I'll quickly rush through it. This is a phase 3 randomized trial for the first line setting of advanced or metastatic TNBC with the addition of atezolizumab to nab-paclitaxel. As you can see on the left-hand side, there was an improvement in overall response rates, a significant improvement in progression-free survival, which was the endpoint, and a very, very modest improvement in overall survival. So due to the hierarchical testing, statistical design, they were really not supposed to look at the PD-L1 positive population for overall survival, considering the OS was not significantly different, but nevertheless they did. And what we landed up with was a 7-month benefit in overall survival for the group that was PD-L1 positive. FDA then went on to grant accelerated approval, and they said this was conditional on a confirmatory study. At the same time, the Keynote 355 data appeared, and this was a similar design, a slightly larger number of patients, and here pembro was used. The chemotherapy was nab-pacli, pacli, gemcarbo, and it met its first endpoint, which was progression-free survival of, in addition, 9.7 versus 5.6 months. However, in the first few interim analysis, there was no separation of curves seen for overall survival. More recent data was presented at ESMO this year, and the Keynote 355 showed again a 7-month improvement in overall survival at a follow-up of almost 3 years. This overall survival benefit was seen across all subgroups, be it of geographic region, be it the chemotherapy arm used, be it the use of adjuvant chemo, less than 12 months out, more than or equal to 12 months out of adjuvant therapy or de novo, and number of metastatic sites. There are a lot of differences between the two studies and a lot of similarities as well. Impassion 130 looked at patients more than 12 months out of adjuvant. Keynote 355 looked at more than 6 months out. The chemo backbones were a little different, and the primary endpoints were also a little different. But both these trials showed an identical overall survival benefit of 7 months. So is this convincing enough? Well, the confirmatory study in Impassion 131 came as a sore disappointment to all of us. If we look at the updated interim results, you can see in the box out there that the PFS is 5.7 months for the atezo arm versus 6 months for the chemo alone arm. And overall survival 22 months for Atezzo versus 28.3 months for the placebo with paclitaxel. Remember here, paclitaxel was used instead of nab-paclitaxel. So how do we reconcile these contradictory results? Was the confirmatory trial inadequately powered? 651 patients versus 902. And remember, in the 651, again, it was a 2:1 randomization. The overall survival of the control arm in Impassion 131 was 28 months. I mean, that's a little hard to believe. That's something we don't really see in the clinic. Whereas it was just 16 months in the keynote and 18 months in the 130 trial. Was it the use of steroids? There's been a lot of debate about that. Was it due to chance? We really don't know. But what we do know is that after this study, Roche voluntarily withdrew its accelerated approval for Atezzo in this indication in the United States after discussion with the FDA. It is, however, still approved for use with nab-paclitaxel in Asia and in Europe. So there are a lot of novel treatment options which are emerging, namely the ADCs and immunotherapy. There are some studies that are looking at combinations of these. There are also some studies looking at combination of PARP inhibitors with immune checkpoint inhibitors. There is a safety concern in using immunotherapy, and this is a very nice publication of more than 1,000 patients. And as you can see, the single agent AEs of any grade are about 18.5%. And obviously, this is higher when you use this drug in combination with chemotherapy. This has led to some very nice management guidelines published in both ASCO and the NCCN. So let's shift gears to the early data. It started with I-SPY 2, which you recall is an umbrella design testing various agents. And here the addition of immunotherapy, namely pembrolizumab, in addition to chemo, improved not only the PCR, but also the event-free survival. And this led to a spate of trials, the Jepar Nuvo, the NEO-TRIP, the Keynote 522, and the Impassion 31. As you can see, they had almost similar arms. Anthracyclines were not used in NEO-TRIP. Some of them continued the immunotherapy in the adjuvant setting. The Keynote and Impassion did. The others did not. And all showed an improvement, significant improvement in PAT-CR and the Delta, except for the NEO-TRIP study, which was a negative study. Consistent findings across both the larger studies, that is the Impassion and the Keynote 522, have been noticed. In both these studies, the addition of immune checkpoint inhibition has significantly improved PCR in the intention to treat population. Node negative and node positive patients have had a similar benefit. And again, the difference between this and the metastatic setting, the benefit is seen in both PD-L1 positive and PD-L1 negative subsets. The question arises, does the benefit in PAT-CR then translate into an improved outcome? So we got encouraging news this year from ESMO Virtual Plenary. This was presented by Peter Schmidt. And you can see that at the fourth interim analysis, there is a clear 7.5% delta at 36 months between the chemo placebo and the chemo pembro arm. This event-free survival benefit is seen across, again, all patient subgroups, irrespective of nodal status and PD-L1 status. And another interesting thing that you can notice on the box in the bottom right-hand corner is that even in the patients who did not achieve a PAT-CR, the addition of immunotherapy seemed to be doing something to the event-free survival, and it was almost 10% better than the placebo arm. Results of the Jepar Nuvo were also presented at ASCO this year to follow up of 42.2 months, and the invasive disease-free survival in the PAT-CR patients was 92% versus 71.9% in the non-PAT-CR group, and this was significant. Furthermore, there was a very nice meta-analysis presented by the Milan group this year, and they looked and they showed that the summary odds ratio was in favor of the immunotherapy, and the addition of immune checkpoint blockade to neoadjuvant chemo significantly improved PAT-CR in TNBC patients. We await the results of NACDPB 59, which is on the similar lines. And there are two adjuvant trials to look forward to, the Impassion 30, which is again looking at adjuvant Atezzo, and the SWOG study, which is looking at chemotherapy only in the adjuvant arm with pembrolizumab. There are many questions that remain in the early setting. we are going to give our patients much more toxicity when we are going to be giving them immunotherapy in addition to chemo. And are we really ready for this? And just to give you an example, in the 522 study, in the adjuvant pembro time, in the adjuvant phase, there was one patient who had a fatal pulmonary embolism and another died of autoimmune encephalitis. So we need to be a little more watchful. There are so many other questions. In case of PAT-CR, can we omit the adjuvant immune checkpoint blockade? What are the strategies then for managing residual disease post-neoadjuvant? Are we going to use capecitabine? Are we going to use it alone? Suppose the patient is also BRCA positive and we know that the rate in TNBC is around 15%. Then with the recent Olympia data, are we going to use olaparib or are we going to combine it with immune checkpoints? So these are all questions that remain to be answered. I'd like to conclude by saying that immunotherapy has come of age in triple-negative breast cancer. We've always struggled with biomarkers, and while PD-L1 can certainly guide us, it is not perfect. The landscape of metastatic triple-negative breast cancer is rapidly evolving. Are we going to combine ADCs in the future with immunotherapy? Are we going to stick to chemo? We don't know that. The situation with early disease is even more complicated. There are many options for patients with residual disease. The overall survival benefit in the advanced setting and the event-free survival benefit in the early setting have definitely made an impact and are likely to be practice changing. However, cost and toxicity will remain major issues for our patients. Thank you.
Thank you very much, Dr. Shona. That was a wonderful presentation and as usual, finishing on time and very clear and crisp.
Thank you.
Thank you very much. So I'd like to request now Dr. Sujit to lead the discussion on this. Dr. Sujit, are you there?
Yes, sir.
Yeah, over to you.
Yeah. Good evening. Thank you, Dr. Shona. I was feeling like I am sitting in a class, hearing the basics and both the clinical benefits and the questions. The questions which I wanted to ask, you have already shown in the slides, and you have said it questions to be answered. So I would like to know, in your practice, how do you choose among which immunotherapy to decide on pembrolizumab or atezolizumab? What is your take on that? Now, the theme of the conference also is choosing wisely. So how do we choose wisely in this context?
So since we're on a forum, I think it's a responsibility of me as a speaker to be quite honest. The only drug that I have used, the only immunotherapy that I have used in triple negative has been atezolizumab, simply because it is more affordable. And the companies have facilitated the testing, the SP142. So in the last a year and a half, I would have tested about 20 TNBCs for PD-L1 in the metastatic setting. Out of these 20, 7 were positive. And out of these 7, 4 were able to take immunotherapy. So I have been using Atezo, but I'm very excited if Merck can help us out with the pricing. I'd be very excited to use pembrolizumab. And I think because of our experience in other indications, we are getting used to the toxicities. We know what to look for. We are not alarmed by the endocrinopathies we see. So it is becoming a part of our practice, but triple negative still, it hasn't been used as much as it should be.
In triple negative breast cancer, we have this concept of total neoadjuvant chemotherapy where we complete both AC and paclitaxel and then see the residual disease and go for capecitabine. Now, right. So as in case there is a residual disease post surgery. So what do you think? Where should we place for the next patient with suppose the finances are not a concern, and you have a young 40-year-old patient? How do you place the treatment? Will you choose NACT with pembrolizumab or other immunotherapy, or you will go with chemotherapy and keep it for a metastatic setting, as we have the data for 355? We have the data in metastatic setting also. So how to choose in this context?
See, it's difficult to ignore the event-free survival that we have seen. And I honestly feel in triple negative breast cancer, your first chance is your best chance. I think in most cancers, that's the case. So if my patient was really affording and had a convincing CPS, because the data is now out for EFS with pembrolizumab, I would give pembro. My question is, if I get a PCR, then nothing. In the sense, then I don't have to worry too much.
Yes.
And I may decide to continue adjuvant pembro as the trial has done. But if there's residual disease, it's going to be a nightmare, because, you know, we're going to be testing for BRCA1 in these patients. Now we've been encouraged to test earlier and earlier because of prophylactic oophorectomies, because of genetic counseling. And then once you have residual disease, then what do you choose first? So do you choose Olympia and do you give olaparib? Or do you, combining the two is really going to be very toxic. And, you know, I don't think any of us are prepared. I don't think even in the West, they're only doing it on trial basis, these combinations. So looking at the Delta and Olympia in a BRCA positive, I would be very, very encouraged to switch to a PARP inhibitor, because I've used it a lot in ovary and again, in early setting, it makes sense. But if there's residual disease, I would have to choose between capecitabine and immune checkpoint. And I really don't know what I'd do at this stage. I really don't.
And yeah, in the first line impression 130, this forest plot, you can see that Asians had, if you see the hazard ratio was shifting towards placebo. And what the pembrolizumab data shows, Asians are also benefiting.
Correct.
So what do you think, what could have made this difference? Yesterday, we had professor speaking about, Tasuko speaking about the gut microbiome influencing the response to immunotherapy. Do you think we are more exposed to antibiotics for our communicable diseases?
I think we all are have a lot of antigens, and we built up a lot of natural immunity to this. So I think definitely the gut biome has and as a result, we've had multiple lines of antibiotics. So yeah, I think that definitely plays a role. But see, remember, these are all subgroup analysis. So the number, as you look at subgroups, becomes smaller and smaller. Yes. Yeah, and when you try to say, I mean, what is the number of Asians there? It is in 2 digits, right?
Yeah, 38 number, 38 patients.
Yeah, I wouldn't. I mean, the power is certainly not enough, and the fact that it's on the other side of the vertical line wouldn't trouble me at all with this number of 38. So I think the number is too small to really say that it's not going to work in Asians.
So one last question, do we need to wait for a phase 4 data from India before we shift it as a standard of care for us?
I think the data is there, and there are colleagues of mine in bigger centers and in tertiary care and in bigger cities that will be using it. It would be, I mean, and just if somebody does a collection, forget a phase 4, somebody just does a real data, world data collection, we will have 100, 200 patients in no time in the next 6 to 8 months, and we will know exactly where we stand.
Dr. Jyoti, anything about experience of immunotherapy in TNBC from your center?
So this is extremely limited, with us as well. So I think Dr. Shona has covered, all the points, all the challenges in clinics, and rest we keep discussing, on chat box or on personal communications. Yeah. So in the interest of time, although, you are doing a brilliant job, Sujit, and I'm really, my apologies for keeping a bar here, because we have to move in time.
I think it has been discussed very well. All the slides are very much, all the questions are answered. There are so many unanswered questions also, but it will take time for the answers to come.
Yes.
Sure.
Thank you so much.
So I'll take this opportunity to formally thank Dr. Shona Nag for this brilliant talk.
Not at all.
And, always supporting IOSI and ourselves. Also, I'm extremely thankful to the chairpersons, Dr. Deo, Dr. Malhotra, and our lead discussant, Dr. Sujit, who's a very dear colleague from TMH itself. And from here, I will give the mic to Rekha for further proceedings. Thank you, everyone.
Thank you, ma'am.
So we are moving to our last session of the day, for which I would like to invite our chairpersons, Dr. AFM Kamal Uddin sir, who is Associate Professor, Department of Radiation Oncology from Bangladesh, and Dr. Gundeti, who is Head Department of Medical Oncology from Nizam's Institute of Medical Sciences, Hyderabad. Over to you, sir.
Good evening. Thank you first to invite me for this session. So we have a panel discussion now, and we have Dr. Senthil Rajappa, very known face and very popular for doing the panel discussion with the senior consultant medical oncologist of Basavatkam Indo-American Cancer Hospital Research Institute, Hyderabad. So I would like to request Dr. Senthil to moderate the session and invite his panelists. Dr. Senthil, please.
Good evening, everybody. Thank you so much, sir. And thank you, organizers, for asking me to do this panel. So here are the panelists, Professor Sudeep Gupta from Bombay, Dr. Navneet Singh from PGI Chandigarh, Dr. Suresh Babu from Bangalore, Dr. Ashish is again from Bombay, Dr. Smriti is a senior medical oncologist from Bombay, Dr. Sahu, my very good friend from Bhopal, and of course, Amit Agarwal from Delhi. So that's the who's who. Rekha, can I have the screen sharing rights, please?
Yes, surely, sir. Sir, just to update, Dr. Bakshi couldn't join due to some personal.
No problem. Thank you so much. Thank you for the information. Okay, so there we are. So if Nitesh thought we were in the Stone Age, I felt like a dinosaur. So that is where we are when it comes to immuno-oncology, I suppose. But then at the end of the day, we have to be realistic. Welcome to India, where we have a totally different set of issues and problems, which we will discuss in the next 30 minutes. Jyoti, I assure you that I will stop by 8:30 wherever we are. Thank you so much. So in the interest of time, I would also request the panelists to be as short and sweet with their answers, one-liners if necessary. A little longer, that's fine. So let me start by asking, we have always felt, when you have a personal conversation with your friends, your colleagues, the moment you say, let's put somebody on immunotherapy, there will be a very sarcastic chuckle, right? So many of us certainly felt, and to a certain extent continue to feel, that there's a lot of hype around immune checkpoint inhibitors. So in the past couple of years or so, has our perception changed? Do we feel that it's much more, it's much more in terms of the value it adds to our patients in terms of prolonging their life, quality of lives? So let me start with Suresh. Suresh is on my screen, so we start with him. So Suresh, has your perception changed? Do you feel that there's still a lot of hype, or there's a lot of substance?
I think it's not hype, sir. I believe that definitely there is a benefit. One of the things which I have observed is that some patients who respond, they really do respond. And patients who don't respond, you can pick them very early, maybe as early, maybe 4 or 5 cycles down the line. We will know that they are not responding. But definitely immunotherapy has done a change in many of my patients. Some of them are on CR maybe almost more than 1.5 years.
Excellent.
So definitely it's not just a night.
Excellent. Very good. We're happy to hear that, Suresh. Amit Agarwal, you echo what Suresh is saying?
Yes.
Excellent. Very good. Dr. Smriti?
Yes, I do echo what he says. And as I said, we'd like to give it to more number of patients, but the reality is it is underused in India, but it has shown good results in the patients who have appropriately been treated.
Excellent. That's a very important and clinically relevant point. Appropriate choice of patients. We'll certainly come to that during the course of our discussion. So what I'll do in the next 5-10 minutes is to discuss disease-specific, immune checkpoint inhibitor studies. So we'll start with lung cancer. I'm just going to look at, in a general perspective, not go too much into the details and the specifics of it, just to get an idea. So let me ask Navneet. Navneet, this is lung cancer data, extremely impressive, very, very consistent. All of these studies showing an overall survival benefit. Of course, there have also been some studies where it's negative, but the majority of it consistently beneficial in terms of overall survival. But let me ask you 2 questions, Navneet. How much have you been able to apply in practice? That's one. And do you see similar results in the clinic? And the reason why I'm asking you this is this data, something very similar was shown earlier during the evening, that the outcomes in the real world are quite inferior compared to what you see in the clinical trials. This is, of course, very biased probably, and also data from a selective set of patients from Medicaid, but this is 20,000 patients. You can't ignore this. What has your experience been, Navneet?
Thank you, and I'll sum it up as crisply as I can. Immunotherapy is not targeted therapy, and the wonderful results which we see with targeted therapy for an oncogene-driven tumor, immunotherapy really does not match that. The cost remains the most biggest hindrance for its applicability in real-world setting. However, there are subsets of patients who do tend to benefit, and I think despite all its limitations, PD-L1 or high PD-L1 patients are the ones who seem to benefit the most from immunotherapy.
Absolutely right, Navneet. I think our expectations are also sometimes unrealistic. We think it's going to be magical in all the patients that we use it. But what has been your experience? Does your experience mirror what I'm showing you on this screen, that you have not been able to achieve what Keynote 024 or 189 has shown, 30 months and 22 months, but look at the data that I'm showing you here. It's probably less than half of what was achieved in the study. So that's the point I'm making. We'll come to how to choose our patients a little later, but I agree with you.
So most of my experience has been in the relapse setting,
right,
not in the frontline setting, and that has primarily to do with the timeline of introduction of these drugs as well as the current cost or cost to the patient as it is. But again, relapse setting is an entirely different perspective as compared to frontline, what is being depicted here. Frontline, whatever patients have been on high PD-L1 on monotherapy or people who are on combo with low PD-L1, they have done reasonably well. But obviously, I don't have the numbers to even come close to what these graphs depict.
All right, very honest, Navneet. We'll show you some of the second line data a little later. We'll show you some Indian data as we go by and ask for your comments again. Let's get to renal cell cancer. Sahu, very impressive data. Again, let me ask you the same question. What are your thoughts? Have you used? What is your impression of the results that you get in the clinic? Is it mirroring what you're seeing on the screen? Lovely results. Again, very, very consistent. Every trial has shown impressive overall survival benefits. Sahu.
In my experience would not be very, I don't have a large experience in this setting in the RCC, but this is one subtype of tumors which has really impressed with its immunotherapy results apart from melanoma. If I put it in the sequence, melanoma and then RCC is something which I would tell that has been the most impressive of all. And this has really changed the way we are going to treat the patients in frontline RCC, at least the clear cell and the sarcomatoid varieties. And that's my take on it.
Excellent. So again, consistent. Amit Agarwal, your experience in treating patients with renal cell cancer upfront.
So more impressive results in RCC compared to non-small cell lung cancer.
Absolutely.
I don't have as many number to say that have I got anybody who has reached 5 years. These are 6-year median survival, but I don't think I started that early 5 years ago. But whatever numbers are, but RCC is a more treatable disease with immune therapy than non-small cell.
And one more thing, if I can add on, Dr. Senthil, the response rate is something that has been tremendous in RCC.
Absolutely.
We are touching a 77-80% response rate, which cannot match ever in lung cancer also. So
do you think that's the addition of the TKI, Sahu?
Yeah, it is. It is. And I think there is addition of TKI and the immune checkpoints. But what I take positive is the response rates also, because patients are sick, would love to have that responses coming to have a better quality of life. So for me, that really matters.
Excellent point. Very well taken. So this is one area where I think there is kind of a universal agreement that we are quite close to what you've seen in the clinical trials. That's what Smriti madam, would you also agree with Sahu and Amit?
Yeah, absolutely. Because I've seen the whole landscape when I could not offer anything to sunitinib. And now I have used this in the first line setting. And of course, the numbers are not big, they're very small. But the experience has been extremely good for me as well as the patient. So long as, you're able to take care of the toxicities. So especially the combination which we can give to our patients like lenvatinib with immunotherapy, very dramatic results and very early response rates. That's important.
Absolutely. So I think we all are on the same page as far as its efficacy in RCC and our experience is concerned. Let me bring in Professor Sudeep Gupta here. Sir, does this bring a smile to your face? Because this is a disease where you are really putting your heart and soul to make patients live longer. The keynote study of Pembro plus Pacli Carbo presented at ESMO this year showing an overall survival benefit. This is data in patients who have a CPS of more than or equal to 1. Your comments?
I think this is very good data, and as you can clearly see, we are always excited when we see an overall survival benefit that is not only statistically significant but also clinically meaningful as it is here. But as for bringing smiles to my face or to other faces, that will have to wait, because as you know, more than any other disease, cervix cancer largely happens in underprivileged women. I don't know what others' experience has been. So, I will wait when this data actually brings smiles to most patients' faces. But the data is good, and I completely agree with that.
At least it's brought some smile to my face. But you're absolutely right. It's more important to see the smile in your patient's face. You made a very important point. Would you dissect, because there was I had the opportunity to watch Professor Mirza discuss this. He was getting into the nitty-gritty of the forest plot and then talking about patients with bevacizumab only benefiting, patients with de novo metastatic disease not benefiting. I thought he was, trying to dissect it too deep when these are not things that you probably should be looking at this point in time. What are your thoughts, Professor Gupta?
As far as I can make out from this forest plot, I wouldn't place too much emphasis on the individual data points. And the reason, as somebody else also pointed out earlier, that subgroup analysis by their very nature are hypothesis generating and not definitive, especially when the interaction is quantitative and not qualitative.
Right.
And if you see here, most of the point estimates are actually to the left of unity. So I don't know what Dr. Mirza was making. And Dr. Mirza is a very learned person.
Absolutely, so and that's what surprised me.
I'm sure he must have had good reasons to make the points that he did, but at least those points are a little bit lost on me, and I cannot sort of say that one group benefits more or less compared to the others.
That's right. So, except that the PDL1, the results were actually being driven by patients who were PDL1 positive. That's something that was very relevant, right? Let me bring in Smriti, madam. Madam, I think the confusion between Atizo and Pembro finally being rested, is that right? Or do you still think you would have a patient where you would want to do SP142 and look at the immune cell positivity and use Atizo?
The data is now heavily loaded in favor of pembrolizumab. And, I would actually, and in many of the discussions in prior meetings, people abroad are doing both the tests, because that there is some overlap, but somebody may be positive for one or the other. So if cost was not a constraint, I would do both. But if both were positive, I would lean towards pembrolizumab, because it's clearly giving an overall survival advantage, and cost is the same. But on the other hand, if they were negative for their biomarker and positive for SP142, then I would use Atizo.
Okay, very nice. Amit Agarwal, would you?
Point.
Yeah, madam, please go
what
ahead.
chemotherapy backbone I am able to use.
Okay.
So if patient is not eligible for nab-pacli, then I have to go for Pembro.
Okay. Amit Agarwal, would you also do SP142, 22C3, and then if the 22C3 is not qualifying, would you go based on the immune cell positivity with SP142 and use Atizo? Would you do that?
Not inclined.
Not inclined to do that. Professor Sudeep Gupta, would you be inclined to do that?
I think the data with pembrolizumab is much more convincing than with atezolizumab, and I have said this earlier as well. Yes. I was never convinced with atezolizumab, but I just want to point out an interesting fact to you. I think a lot of store is placed by the fact that the tail of the curve has a plateau in all immuno-oncology or in many immuno-oncology studies. I just like to point out the control arm to you here, and you can see that there is actually a plateau and a number of patients are censored far into the future, even on the control arm.
Correct.
So, I also want to make the point that whatever treatment one uses, a proportion of patients will do well in the long run. Of course, it does. It is definitely the case here that a slightly larger proportion of patients do well in the long run on pembrolizumab compared to the placebo arm. But any treatment that you use, there will be a tail that will stretch far into the future.
Absolutely. Probably there's a small set of patients in each of these arms where they have good biology, at least, they respond better to the. Yeah, Sahu, please go ahead.
Yeah, just put that I am passion 130 curves in parallel to this. Both these curves look similar.
That's what.
And the only thing is,
yeah.
The only thing is that the OS is the hazards is little better for the probably the IM power. But the only thing that comes out is that you select a more higher PD-L1 or a CPS score positive, and probably that's where the immuno-oncology is working. That's probably the only thing that's going to be emphasized in the future trials.
I know, yeah. So I think that brings into the question of the theme that we keep on saying that triple negative is a very immunogenic disease. But if you consistently see the early disease, PD-L1 doesn't seem to be a great predictor, or you probably don't have to do the test in order to use. We'll come to that very soon. But when you come to the metastatic setting, it is not as plastic and as immunogenic as the early stage tumor. And Dr. Shona Nag very nicely showed that consistently you need to pick up those patients with a high PD-L1 for you to show some benefit. So I think metastatic TNBC, the immune environment is quite different from the immune environment that you get in the early TNBC. So that is a point that we need to be very cognizant about, and that's why you're seeing some of these differences also, right? Okay, so we move from the metastatic setting to the early setting. So Sahu, let me bring you in here. So these are three curves that I'm showing. One, this TechMate 577, G junction, nivolumab in muscle invasive bladder cancer, and pembro in kidney cancer. 2 or 3 questions here. So all of these are likely to be approved, or some of them are already approved based on the event-free survival as an endpoint. What are the relevant things that you want to know as an Indian physician before you apply this in your clinic? Will you just say that I'm fine, I'm happy with this and go on, or do you think you want more data before, let's say, follow up and so on and so forth? What would you do, Sahu?
Let's look. Yeah, definitely. I would like to have a longer follow up because these are costly drugs. They're going to burn into the pockets.
Right.
And I feel that if you look at the RCC, high risk RCC, it's quite, the follow up has been, if I'm not wrong, quite short at this point of time.
Right.
So I would like to have a longer follow up in most of the disease. Second point is the how.
So Sahu, just a moment. Sahu, sorry to interrupt you. This was again discussed in the discussion part of that, abstract being presented. The author said when sunitinib came, you had to wait for 6.5 years of median follow-up to see some difference in disease-free survival. And here you're seeing a nice separation early during the course of the follow-up itself was the counter argument or the point that the author actually put forward when somebody said we need to wait for longer follow-up. So that's just a point.
I agree. I also want to point out the reality in which they live and we live.
Absolutely.
That is where it kills the whole thing. And if that is put in perspective Indian context, I would like to go.
So you would like to wait for overall survival benefit?
Yeah.
Is that
because these are 2 years of
your
therapy,
point is well
definitely
taken. Absolutely. Nothing wrong. Your opinion is very much valued. Amit Agarwal, would you also want to wait for overall survival before you adopt any of these in clinical practice?
No, I don't think so.
Okay, so you would.
These are very impressive curve separation.
Okay.
And I don't know. I mean, all these patients, RCC patient, for example, would never show an overall survival.
It's difficult.
The moment that the patient will relapse back would definitely have an immunotherapy in the first and the second and the third line. So I don't think overall survival will come up. Okay. If you were to say that we would like to wait for a progression-free survival or an event-free survival over some time, one can wait. But I really doubt for an immunogenic tumor like RCC to show an overall survival unless until you bar the placebo group to ever have an immunotherapy, which is impossible.
Does it not make a counter argument that then in RCC the same argument holds good? I would wait and just give a selected who relapse the immunotherapy oncology drugs because of the Indian circumstances again.
So
But yes,
whenever I ask the
agree,
patient,
agree, Amit.
now
Yeah.
you listen to me, I've said.
So,
Whenever
Amit, go
I
ahead.
ask the
Amit, go
patient
ahead.
that
Sahu, hold on. Sahu, hold on.
yeah,
Amit.
whenever I ask the patient, I can give you a drug now, or I can give it to you when you relapse back, and you may not relapse back if I give the drug now. The patient always say, I want a drug now. I don't want to relapse back, and then take the drug. None of them have agreed to me that why do you want to have a drug now when I can give you the drug maybe 5-6 months or 2 years later, and maybe your overall survival will be almost same. Nobody agrees to it.
Suresh, what would be your thoughts, Suresh? Ready for adopting in clinic or
Yeah,
wait
yes,
for
sir. I
overall
think I
survival?
agree with Amit sir, because I think the RCC and all, we are not expecting it to, show really great difference in overall survival. That's going to take a lot of time. I agree that when we
Suresh,
discuss.
what about, let's say, muscle invasive bladder cancer? Is that a disease where you would like to wait? Because as little as I have seen, they come with disease, they're just gone.
Yes, sir. Because the thing is that, as Amit sir was telling, when we discuss with the patient the options, they always want the best. Apart from the economy, what Dr. Sahu was referring to. So when you say that we have this regime, we think this is the best regime, which whatever regime we choose, we don't expect it to do well for every patient. But when you sit in a discussion in a clinic, every patient wants the best. So when you know that the drug is best and it's the best choice, I think obviously we will offer them.
Excellent. Professor Sudeep Gupta, I know these are not malignancies that you manage, but what would be your opinion on EFS versus OS as an endpoint in these immune checkpoint inhibitor studies?
So I just wanted to add and support what Amit and Suresh just said. So in the non-metastatic setting, it is not just the length of life that a patient is concerned with. I think prevention of relapse is a very important endpoint for patients. And the second point that I wanted to make was that in the adjuvant setting or in the non-metastatic setting, the drug is often or almost always used for a defined period of time, unlike in the metastatic setting when it goes on ad infinitum until disease progression usually. So I think many different cost effectiveness analyses have also pointed out the fact that prevention of relapse of a fatal disease like cancer actually is cost effective, and the drugs, if they have been shown to have so the only caveat to that is that I would not suggest a drug to be adopted when the quantum of DFS benefit is very small.
Point well.
If the quantum of benefit is like what the curves show here, I think it makes sense to adopt the drug in the non-metastatic setting.
Point well taken and agreed.
Can I make a point?
Madam, please go ahead, madam.
Yeah. I mean, where RCC is concerned, the relapses occur late. So you're unlikely to see overall survival benefit so soon. But knowing the data from this, I would definitely discuss it with the patient. I just won't leave it just because overall survival data is not available. And also so with the G junction tumors. And as you mentioned, where the bladder cancer is concerned, once it comes back, it's so fatal that you want to cling on to anything which shows a benefit in the adjuvant setting. And in this setting, everyone wants the best and as everyone stated, prevent a relapse. So I think these have to be discussed with the patient.
Absolutely. I think the point is well made that all of us value EFS as an endpoint as long as we think that this benefit that you're getting is clinically significant and more importantly relevant for our patients. And it is we may have our personal opinions on waiting for 5 more years to get overall survival benefit, which is in a way right. But it is important to discuss all of these with our patients and make this patient-centered care rather than disease-centered care only. Take them into your decision making and then do whatever is the most appropriate for them. I think that's the way I would look at it. 2 quick questions. Amit, I think you must be getting ready for the Tuesday. So I thought it will be appropriate to ask you the question of whether patients with PCR need adjuvant pembro. And the second question is based on the JEPAR NUO, though it's a very small study, 174 patients, nothing compared to KN522, the AFS was almost similar to the Keynote 522. So do you feel that a shorter course would be good enough, just the neoadjuvant, or, I really don't know how short is short, but what would your thoughts be, Amit? Because we are cost conscious and it's, Herceptin short course, pembro. What are your thoughts?
So, Senthil, that's a great idea. So that's a great thought process. Do we have an answer to that question? I just don't know.
Correct.
I mean, you have made the thing bold, suggesting very clear point that the PCR achieved by a non-immunotherapy drug and a PCR achieved by an immunotherapy drug sounds similar. You can hardly raise the bar from 92 to 94. There's not much to be achieved. You can't predict who will achieve PAT-CR, but once you have achieved a PAT-CR, the incremental benefit of immunotherapy continued will be, logically speaking, less. The achievement that has been there has been there. I mean, you know what I mean to say.
Yes.
Possibly the incremental benefit is much more when the PAT-CR has not been achieved.
Absolutely.
I mean, I'm just guessing so. At this point of time, can we don't know. Once the adjuvant immunotherapy trial comes into picture, they may answer this question. Whom would be getting an adjuvant immunotherapy? Would they be non-PAT-CR achiever, PAT-CR achiever? I don't know how those trials are planned to run, but at this point of time, it is intuitive belief, and I may be wrong, that possibly the non-PAT-CR patients are achieving a better benefit. But I think I don't think it's clearly answerable at this point of time. But I certainly, if there's a patient who is landing up with money trouble and has achieved a PAT-CR, my own stress on continuing would get lesser, because they're short of money, and in my mind, the incremental benefit in these patients may have already been achieved by giving neoadjuvant, but anybody's guess.
Right. So let me ask Professor Sudeep Gupta, sir, just a thought process. I just like to know your views. I did discuss about this last week. So let's say somebody is coming with a tight budget, saying I will be able to take that 6 months of therapy, and you don't achieve a PAT-CR. Amit is absolutely right. The benefit seems to be higher for patients with PAT-CR than those who achieved than those who achieved a PAT-CR. So if I said, okay, let's try 6 months. If you don't achieve a PAT-CR, let's get to capecitabine. Would that be okay for you? What are your thoughts on that? I know that's not the study, but in an Indian setting, would that be acceptable?
So I think I agree with Amit when he said that patients who do achieve a PAT-CR are likely to have a very small incremental benefit of continuing the pembrolizumab beyond that time point. Of course, that small benefit cannot be ruled out. Now, to your point of whether if somebody has a tight budget, would I start them on pembrolizumab or not? I think no. Given this data, I would definitely, if the budget allows only for the neoadjuvant component, regardless of whether they will or will not achieve a PAT-CR, I would possibly go for it. That's how I will look at it. But then, this cannot be a purist recommendation. This is rather a practical recommendation.
Absolutely. So go
I
for
would
it.
say that yes, I would go for it if the budget allows only for the neoadjuvant component, then so be it.
Great. So, and then we can always break our head over, what to do if you don't achieve a PAT-CR. Capecitabine is always our go-to drug when you get to a point like that. But I think these are some questions that are going to come, and I don't think, at least to my knowledge, there's a clinical trial that's trying to answer a question like this. So we have to do our jugaad in situations like this and, help our patients to get the best out of these. But I always keep getting that impression that at least in the adjuvant setting, the perioperative setting, you probably don't need such long durations of any immune-mediated treatment itself. I may be right, I may be wrong. Okay, a very important question here. So accelerated approvals, Atizo in TNBC, nivolumab in HCC, Atizo in metastatic urothelial cancer, second line, all of them were given accelerated approvals, but the confirmatory trials turned out to be negative. Interestingly, the FDA has not withdrawn any of these approvals, but very nicely, the companies have withdrawn all these. What is your view on this? Smriti, madam, let me start by asking you. Do you always look back and feel bad? Oh my goodness, what did I do to my patients? I used so much of drugs, costly ones, and then now it looks like these drugs don't actually benefit. Do you for a moment, have you sat down and thought, oh my goodness, I shouldn't have done anything based on an accelerated approval? What would you think?
Well, I know this leaves a lot of patients who are already on the drugs in the lurch.
That's another problem.
Because, you don't know what to do. Although, some people were asked and they said that if the patient is benefiting, they would not want to discontinue the drug.
Correct.
So that is regards to patients who are on these drugs. But if you were to consider now patients whom you would like to put on the drugs, then it does leave you in a quandary, and it does show that sometimes these accelerated approvals, could lead to problems. But given the diseases that are being addressed here, one tends to use them when there is even an accelerated approval.
So why do you think, madam, the FDA is not pulling the approval back? Because my understanding of an accelerated approval is you give an approval and then you tell the company to come back with a confirmatory study, and you continue with a full approval only if the company comes back with the study. And here you always have a situation
Yes.
where companies come back with negative studies and FDA
Yes,
keeps the
that's,
approval.
Atizo is a very good example of that, because, in the intent to treat population, they couldn't show the benefit overall survival. So the hierarchical testing could not be
Correct.
done
So
in those, even
finally
if
a
there was a
negative study.
7-month difference. So this sort of problems are going to arise in these diseases. But as I said, that the FDA has withdrawn the approval in the US, but not in the rest of the world, as far as Atizo is concerned. So I think, I would still use the drug for an accelerated approval.
Okay. Professor
Sandil boss.
I don't have other options.
Yeah. Sahu, go ahead.
No, I think with that they do not remove it for outside US, and US is they want to keep their person safe, and that's the only thing that can be made out of.
I mean, I kind of doubt Sahu. The
I
guys sitting in
know.
the FDA are not. We may have our opinions on that, but guys sitting there are not fools. That's why I wanted to ask somebody who is involved in all of this.
That's it, Dr. Sudeep,
Professor Sudeep Gupta. I want to ask you, what is your insight on what's going on? The FDA not pulling the approval back. Is there something behind that?
So I don't know about that. I think behind the closed door discussions, the FDA might have conveyed to the company that if they don't pull it back, then the approval will be withdrawn. And both giving the approval and withdrawing the approval is a deliberated process. It doesn't happen in a jiffy, especially with an agency like the FDA. I just want to say that despite all the criticism of the accelerated approval process, I think it is a very nice mechanism, because we tend to play up those studies which did not meet their endpoints in the confirmatory studies. But we must also understand that there are many studies where the confirmatory study did sort of validate the findings of the accelerated approval. And for a person who's here in October 2021, that opportunity to get treated with that drug will never arise. The only caveat in my opinion, to the accelerated approval process should be that once there is a negative confirmatory study, then the approval must be withdrawn. It should not be left hanging on the shelf so that people remain confused forever after that, which has actually happened to a few drugs.
That's right.
Sudeep sir, one simple question.
Yes, Sahu, go ahead.
What Sandil boss told, that it is okay, withdrawal approval for a country specific and okay with the rest of the world. How do you convey? What does it convey?
No, but Dr. Sahu, how do you know that they will not withdraw the indication in other jurisdictions as well? You see, it can't happen that the data is presented today and the withdrawal happens tomorrow. It is quite likely and possible that perhaps the regulatory agencies in the other jurisdictions might have a slightly different take on that issue. And although I have never been a great fan of atezolizumab in breast cancer, for argument's sake, I could still present in a debate, I could argue still strongly in favor of atezolizumab and cut up the data in various innovative ways to say that it does help a few patients. So I think, we should not be too critical of the entire process. It's good that they've withdrawn the indication in US, and who knows, it is likely that they may withdraw it in other jurisdictions as well.
So, and Sahu, correct me if I'm wrong. I think we don't, run by what the FDA says or doesn't say, isn't it? So FDA is just taken as a, worldwide. Uncle Sam has to say whatever you want to hear, and only then do you follow. So I don't think the FDA will go about saying stop it in India. Stop it in
I also want to say that despite all the criticism of the US FDA, it is one body that has the most robust mechanisms for appraisal of all data and all drugs.
And that's why, that's the exact reason
we do tend to rely on their judgment, because we know that they do a reasonably good job of it, and we don't have that wherewithal to actually do it ourselves.
And that's why
that's
we
exactly
endorse
what
it. We are not So Sahu, I think we'll move on. So that's why we kind
we'll
of
move on.
endorse
We'll
it.
move
We are
on.
not bound by it. So that's
Agreed,
the way I would
agreed,
look
agreed,
at it. So
agreed.
I agree with what everybody has said. So at that point in time, it looks fine. But then when the confirmatory study is negative, you need to take it back. That's something that we would expect them to do. So this is a Herculean. I'll finish in the next 5 minutes. This is a Herculean task put in by Jyoti and Abraham, her resident, if I'm not mistaken, putting in data of more than 1,000 patients from 13 centers on the use of immune checkpoint inhibitors in various diseases. The median number of cycles was 5, median duration of therapy was 3 months, something that is not in tune with what you would expect out of immune checkpoint inhibitor use. 68% discontinued for disease progression, a quarter of them for financial reasons, and some of them for toxicities. So Amit Agarwal, does this data reflect your practice? How many marks would you give the investigators who are part of this study on 10? For the way they have done with immune checkpoint inhibitors.
You're one of them, so
yeah. So please.
Marks to you. Anyway, so I think this was a very heterogeneous study. We all participated in. You participated in it, and this was some patient had 2 cycles of immunotherapy. You know, this study had patients started on immunotherapy 4 or 5 years ago.
Correct.
And some of my patient had taken for 2-3 months only. We were learning how to administer immunotherapy. What was progression, what was not progression. Some people could not pay for it, which is very fair. If you were to do this study again now, and I'm pretty sure that the data will be very different.
Absolutely, it will certainly be better.
Time we choose our patients well, we understand what is progression, regression, and how to interpret that. And I think we would have a completely different data set. So it is sobering to know that real world data set can be very different from the known data set. That's very sobering. But I think we all have a learning curve.
Agreed, absolutely agreed, Amit. And I also think it's not too bad at all. It's not very different from the databases in the Western world where we think people know to use this better and patients are doing superbly well. So it's not very different from that. Navneet, here is data of non-small cell lung cancer. Most of these patients were in the second and third line. I don't think there were almost no patients in the first line, if I'm not mistaken. 7.1 months PFS and an overall survival of 14.2. Your comments, Navneet, doesn't it reflect what exactly happened in these studies?
Yes, so I think we have to factor in that the caveats of this retrospective analysis and pooled data with the missing data in between. But yes, this is largely what you would expect in a relapse setting. If you were to do a prospective study or a prospective trial, have greater number of patients in the first line setting, you would get much better results, I assume. But right now the reality is that these drugs are very, very expensive and most patients do not afford it. And I think it's, I don't know where the solution lies, but as clinicians and as administrators, it's our job that the prices come down and a greater number of eligible patients actually get the drug. And it's only then that we'll see an overall improvement in outcomes for the cohort of patients as a whole.
Excellent. So, after having listened to the whole evening, what I get a feeling about is that the therapies are certainly getting better. We are struggling with biomarkers, but that might get better. But the other feeling that I get that as therapies are improving, the resources that you need to be able to put that therapy to the practice in your patient is not going to be so easy. So with therapies improving, we may actually be moving away from implementing that in our patients, at least in a country like India. That's the kind of feeling that I get. So let me get a quick, thought on this from, our panelists. Let me start with Professor Sudeep. So biomarkers are getting more and more complicated. We're looking at immune signatures, consecutive, sampling, RNA, DNA, omics, many things that I don't understand, except that the pictures look colorful. And as you keep adding on one therapy to the other, it's only becoming more expensive. We are struggling with just using nivolumab or pembrolizumab. So in the Indian context, what do you think? Where are we getting to, and how applicable will it be to our patients?
I 100% agree with you that the treatments are getting better, but they are becoming less and less accessible to patients. And in an interview with you yesterday, I used the analogy, or I don't know where, with somebody else, I used the analogy of the iPhone. Somebody said that the phone was now more and more accessible, but I said that it is the latest iPhone that is not accessible to everyone.
Correct.
As far as the biomarkers are concerned, I think immune system is pretty complex. And our reductionist approach to try to find a clean biomarker, we have PDL1. I am not very clear whether we will actually have a great biomarker anytime in the near future.
I very much agree with whatever you're saying. Smriti, madam.
Yeah, I agree that, cost is a major issue, and, we have to explain all this to the patient, and that is one of the things that's a major hurdle. And, you're hearing of so many new drugs in all spheres, and we know that we cannot access these drugs. So we just seem to hear about it and then not put it into practice. I only hope that just like one of the drugs now recently, the anti-HER2 Kadcyla, we've got a generic that, our companies are able to make more generics and make it more accessible. I mean, that's what I can say.
Hopefully that will happen. Answers from Amit and Sahu for the question that I am showing here. Do you think we will ever have high quality phase 3 randomized studies to look at lower doses, less frequent dosing and lesser duration? Amit, Sahu.
Somebody will have to pay for such kind of trials. Who will do it?
That's why I'm asking you, will you ever have high quality evidence?
It is our problem and it is our job. Who will do it?
Okay, so we will check who will. Sahu, will you be doing it?
No, there are two things that I would like to tell. It is going to happen definitely, but it is a society, maybe organizing a SWOG or someone who has to do it and do the funding. No company is ever going to do it. For the last one, I just have a very quick one-liner. I think the science is getting better but difficult. You don't study for 1 month and you're out of the job. The second point is we as doctors have to now stand up, read and offer the best. And third, the government has to make the drugs cheaper. Something has to be done. Otherwise, it will be just in the panel discussion we will be discussing.
That is
Next
why
day, it will be,
This is a slide, the previous slide and this slide I showed last year when Jyoti wanted me to do this panel. I'm showing this and I hear a lot of what I heard last year. At least I remember a few of things, if not all of them. So we are still stuck with those lower doses, less frequent dosing, shorter period and so on and so forth. I think at some point in time, we ourselves will have to take the initiative to, do something on that line. So this is my last slide.
We have understood this drug better. That's what the only thing has happened.
Very good. I think we are certainly better this year compared to last year, Sahu, and I'm sure the next couple of years will be even better. So let me ask, our panelists this last closing question. What is the one thing that you would want in order to make IO more accessible to a deserving patient? I made a big list there. You can add anything else. Let me start with Suresh.
I think biosimilars is the answer. Sir.
Biosimilars. Professor Kamaluddin already has it. He's ready with a job for you.
The lower doses and less frequent administration.
Okay.
Actually, it happens practically, isn't it? Many times happens that
we do it.
Say that, sir, I didn't have money. We came. The other issue was, I think, Sudeep sir was telling there was so many markers, so much confusion. Correct. We have been learning, isn't it? When immunotherapy came to lung cancer, we had a lot of discussion about more than 50%, 1 to 50%. Now we have a clarity. I think we'll learn over the time. Covering government scheme will take a lot of time for the immunotherapy to come. Biosimilars is something.
Madam Smriti, madam.
Well, I think biosimilars is the way to go. Okay. And of course, as mentioned before, and even Peter Solange mentioned that, you'll never get anyone to fund the lower doses and frequent administration from the companies. The only point I'd like to make here is, as a community of medical oncologists, we should try to enforce the insurance companies to cover these drugs, because there are many insurance companies who are not ready to cover immunotherapy and targeted therapy. So we should make
maybe the society can take that up. You made a very important point, madam. So maybe the society can take that up. Amit, all the five, as usual.
Yeah, there's one additional point if the time conveys.
Yeah, quickly.
Cost is the only angle which, whether the company makes it cheaper or whether the biosimilar makes it cheaper, it has to be affordable. If you would read 522 appendix, there is a long calculation of why they accepted 200 milligram of Keytruda. I'm talking about
Yeah,
5 to 2.
yeah. I think that was discussed in a WhatsApp group also, isn't it? At
Is
some
it?
point in
So
time. Yes.
in that appendix, they clearly established the fact that 2 milligram per kilogram was equivalent to 200 milligram per kilogram in area under curve, and then therefore they decided to use 200 milligram.
So,
And I thought, why didn't you use 2 milligram per kilogram? That could be the same algorithm to
essentially
say.
correct. So essentially, it was arbitrary.
So if it was arbitrary, it helps us a lot. We have so many 50 kilo ladies
That's
who
correct.
can easily go to 100 milligrams. So, they have approved 2 milligram per kilogram for second line NSCLC. But for the rest, they've chosen 200
So
milligrams.
essentially, it is to bring down the cost. Which is the best way to bring down the cost is the question.
Just practice in tier 2
Saul,
city, the last point.
Yeah, last point quickly, and then we'll close.
If you really want this drug to reach the masses in the practice in tier 2 city for 15 years now, it has to be under government scheme.
Okay,
And
it
there
has
has
to
to
be
be
under
a
government. Good.
Otherwise,
Very good.
rest
Improving
all we can
access.
go and discuss.
Professor Sudeep, you have the last word, and then I'll close. Jyoti will otherwise throw me out.
But
Yeah, Navneet, and then Navneet, and then Professor Sudeep.
So this is going to take time and money, getting biosimilars, Indian companies to manufacture this, getting IO covered in government schemes. That's going to be a phenomenal effort.
What is the low-hanging fruit, Navneet, then?
What is really needed is trying to figure out the appropriate quote-unquote lower doses for our population. I think TMH and AIMS have already got a grant to do this study, from what I am aware. And they are going to be working on a lower dose / poor administration. That's the way forward till such time that Indian companies actually come up with biosimilars.
Professor Sudeep, you and then we end.
So I have nothing more to add. I think everybody has said all the important things, but biosimilar is the most important thing.
Great. Thanks so much, all panelists. I think we had a lovely discussion. I was able to cover most of what I wanted to say. And we are certainly better this year compared to the last year, because I did the same discussion. And I'm sure if Jyoti calls me again next year, I'm sure we will be much better than what we are this year. Thank you so much, Jyoti. Thank you so much, Professor Atul Sharma. Thank you so much, Dr. Amit, for asking me to do this panel. It's always a pleasure. Thank you so much, and take care. Good night.
Thank you so
Thank you very much. Thank you very much, Santil, for this excellent discussion. And as I said you before also, and I'm again want to put on record that you are Mr. Fix-It, and you did the best summary job. That's why I call you for each moderation each year. And
Thank
I
you
will
so
keep
much,
calling
Jyoti.
you in future as well.
My
So with
pleasure.
this note, thank you, all the panelists for this intense discussion. I really love all the comments, and definitely we will be improving, and we will be better in future when we will do the future discussions. This is the ending of the second day of IOSI Third Annual Congress. And on behalf of my co-organizers, I am thankful to each and everyone for your great participation. And we could complete in time also, just 10 minutes, past. And thank you everyone for that. This is a time for a picture. If everybody can please on their cameras quickly. Rekha, can we do that?
Yes, ma'am.
So all of you, please request everyone to please on.
Yeah.
So okay, so whosoever we are here, right?
Yeah, done, ma'am.
Take more. You have not signaled, so I think people were not having smile on their face.
Yeah, so can we have a smile?
So the best way to ask people to smile is to ask them not to smile.
And also to say, sir, that cost is cutting on IO. So this can bring a smile on everybody's face.
Yes, ma'am.
Thank you, everyone, and good night.
Thank you.
See you tomorrow early. Yeah, thank you very much.